for the delay that we could, but again, there were some of the logistic reasons because of that. The program initiation had to spread this much. But anyways, let us start the event, the Cardiosphere. So to start with, it's a very good afternoon. And again, there was a nice rain outside. So it actually indeed a good afternoon. So a very warm welcome and good afternoon to all the esteemed dignitaries and distinguished doctors. It is our pleasure to have you all here in today's program, which is known as Cardiosphere. My name is Dr. Mohit Changani, and it's my privilege to be the master of ceremony for today's event. Further ahead in the program, an extensive scientific sessions are lined up. So without further ado, without wasting time in other formalities, I'd like to move on to the next step of today's program. And for that, I'd be inviting our Chief Operating Officer, Dr. Vijesh Kumar Gupta, for his welcome note and warm words for the session. So, Dr. Gupta, please.
Thank you, Dr. Mohit, Dr. J.C. Mohan, all dignitaries. My name is Dr. Vijesh Gupta, and I head this company, Cadila. It's a privilege to be part of this group. In fact, it has been almost 2 months that I have joined this organization. I have worked in this pharmaceutical industry for more than 30 years and been associated with the companies which basically strongly believe that furthering scientific and medical education amongst the medical fraternity is one of the very, very important role of the pharmaceutical industry. And, after coming here, I felt that, this needs to be taken further. And we have a very strong medical department within the organization. Dr. Mohit is part of them. And we have a very strong team who is committed to ensure that these events keep on taking place. And we really, come out with some meaningful contributions from our side. I'm myself a qualified medical doctor, but into the pharmaceutical industry. So I know both the sides, and I strongly feel that, how important our role can be and how important the role of medical fraternity it is, because they also keep on stimulating us to bring new therapeutic options, which help the medical fraternity itself in managing the disease and the complications of the disease in a much, much better way. With this, we are privileged to have Dr. J.C. Mohan, who is the conference chairman and who graciously accepted our invitation. In fact, I called him and told him that now I am in this organization, and he has always been very, very close in all the programs which I had been, I did around 30 years back when I was a medical advisor, and Dr. J.C. Mohan had been the most prestigious speaker even then and even today. Dr. J.C. Mohan has really designed a very qualitative scientific program. I'm sure that this is going to help all of us, not only the doctors, but also we sitting in the pharmaceutical industry. So, Dr. J.C. Mohan, I invite you to take over the overall proceedings. Yeah, and before that, I think our team would like to show a corporate video of Cadila. And thank you very much. And I look forward to interact with you over your stay. And I believe that your stay today and tomorrow becomes a very enjoyable one. Thank you very much.
Is this little thing in our core. That little thing is called hope. The hope in our core drives us to seek out better futures. It pushes us to innovate our present for a safer and healthier future. Every time we took the lead and invented the treatment for something once considered untreatable, It was because we don't believe in waiting for the future. We believe in innovating and creating it. All this is because our hope for a better world pushes us to. We don't believe in just talking, we walk the talk. Polycap, world's first 5-in-1 polypill for primary and secondary prevention of CVD. Cardiosphere, India's first influenza vaccine for virus-like particle and nanotechnology. Mycidex C, the first active immunotherapy for lung cancer. Rizorin, world's first booster rifampicin for treatment of tuberculosis. TH rabbis, world's first novel free-dose rabies G protein vaccine using virus-like particle VLPS technology. And Sepsivac, novel immunomodulatory therapy for the treatment of gram-negative sepsis. Sepsivac offered 11% absolute reduction and a 55.5% relative reduction in mortality in patients of gram-negative sepsis. Our innovative drug, Sepsivac, as an immunomodulator in sepsis, was found to boost the innate immune response and increase resistance against the progress of COVID-19. And it is because of the determination of over 9,000 people from over 100 countries that we have been able to achieve what others thought was impossible. Cadila Pharmaceuticals, driven by the passion to transform the present and...
Yeah, thank you. Thank you for the video. And at this point, I'd like to thank Dr. Gupta also for his kind words and befitting preface for the occasion. And as he said and he mentioned the role of Dr. J.C. Mohan for conceptualizing and drafting the whole program. I must say he actually was a beacon for us when we initially thought of having such a program that we would like to put our first step into the business of chronic diseases. So it was Dr. J.C. Mohan, without the support of which this conceptualization as well as the actual materialization of this program, particularly the robust scientific agenda, that wouldn't have been possible. And when I talk about Dr. J.C. Mohan, he is such a personality who doesn't require any introduction, any formal introduction. Right from our country as well as abroad, almost everybody knows him. He has been there in the field since last 40 years. And these 40 years has actually been quite an illustrious career he is having. So without going into the depth of his introduction, which he well deserves, I'd like to invite Dr. J.C. Mohan sir, who had been the course director for the Cardiosphere program, over the dais, and to invite and welcome Dr. J.C. Mohan. I'd like to ask Dr. Vijayesh Gupta sir to invite him with the flower bouquet. Dr. J.C. Mohan sir, please. Now I'd like to request Dr. J.C. Mohan sir to grace us with its kind words regarding the program. Thank you, sir.
Good afternoon, ladies and gentlemen. I am J.C. Mohan, and I'm a practicing cardiologist from New Delhi. Welcome to this initiative called Cardiosphere 2023, a North chapter, an initiative which has been possible because of unrestricted educational grant from Cadila Pharmaceuticals. And I have to express my gratitude to Dr. Vijayesh Gupta, the Chief Operating Officer of Cadila Pharmaceuticals, for having agreed to conduct or let us say payroll such a program. Such programs have been envisaged by Dr. Gupta long back, and I have been a part of some of those, I think about 25 years back, if I'm not mistaken. And we did manage to travel a big part of the world with him in connection with programs which are exactly similar to what we are going to have today. So what is the need for Cardiosphere? Why do we want actually to have this kind of program wherein we could have a focused discussion for 4 or 5 hours and also actually meet and greet friends? Cardiovascular disease is the number one killer of the mankind. And in this country, as of now, which is mid 2023, nearly 31% of all adult deaths are as a result of cardiovascular disease. Data from WHO and other agencies suggest that by 2030, 36% of all deaths, all adult deaths, would be because of cardiovascular diseases in this country. And we would actually have over 75 million patients with atherosclerotic cardiovascular disease. That is a tragedy because world over, atherosclerotic cardiovascular disease is coming down with regard to mortality, although the prevalence may not have come down that much. In this country, both prevalence and cardiovascular mortality is increasing, and reason lies in poor control of conventional risk factors like hypertension, dyslipidemia, diabetes, smoking, obesity, so on and so forth. Some of those risk factors we would be touching in this meeting, like dyslipidemia and hypertension. Of course, we know that our first symposium is on hypertension, and hypertension affects more than 250 million Indians and is a major cause of considerable morbidity and mortality, and of course, a major underlying factor for atherosclerotic cardiovascular disease. We would discuss what is conventional, what is known, and what is in future, especially knowing that the drugs so far we have been using actually are working at the level of enzymes, receptors, ion channels, and working as ligands. And now we are trying to look at agents which could actually be used for primary prevention of hypertension or primary prevention for that matter diabetes and dyslipidemia in the form of vaccination, which means we could introduce a modified type of renin or angiotensin 2 against which antibodies will be formed, which will act on the native renin, angiotensin 1, angiotensin 2, and will have control of blood pressure in a similar way with the LDL and LP little a. Of course, we know that a big leap is taken forward with regard to monoclonal antibodies against these proteins, small interfering RNA molecules, and of course, antisense oligonucleotides, which all are capable of giving in future significant handle over prevention and management of hypertension, dyslipidemia, and diabetes. This session, we wouldn't be covering diabetes. You can't cover everything actually in a 4-hour session. Our second symposium will be on dyslipidemia, and we'll talk about third with regard to antiplatelet drugs. What is new about regimens? You might have seen that in last 3-4 years, enormous number of publications have come with regard to antiplatelet therapy. And we will be discussing that subject in great detail because that concerns not only physicians, but everybody. Be it anesthetist, general surgeon, orthopedician, plastic surgeon, neurosurgeon, how much to give, when to stop, when to restart, which one to continue, a lot of those issues which we'll be discussing. And of course, we'll also be discussing a common thread for all these disorders, and that is commonly prevalent vitamin D deficiency and management of hypovitaminosis D in prevention of cardiovascular disease, whatever evidence we have got, and of course, management of cardiovascular disease. And I said, whatever evidence we have got and what are we looking for in future, we would be discussing. I'm extremely happy that we have markedly talented faculty. And I am so happy to see my friends, Dr. Bashir Naiko, Dr. Modi, Dr. Satbir, Dr. Rajiv Rajput, Dr. Subhash Chandra, and many of more, Dr. S.K. Gupta, Dr. Madhu Shukla, and many more people whom, of course, I'm not naming. I think we are going to have a discussion, a meeting which is going to be informative, educative, interactive, and informal. With all those words, I again welcome you to Cardiosphere 2023, and I'll ask Dr. Mohit Changani to set the ball rolling with the first symposium. Dr. Mohit, please.
Thank you so much, sir. Thank you so much. And it was very, very precise depiction and precise explanation of the need as well as the whole program that why we are having. So as sir said, we would be touching upon 4 of the major subspecialties, if I may say, of cardiology. So first would be the session on hypertension. That would be followed by the session of dyslipidemia. Then we would be going towards the antiplatelets and anticoagulants. And last, we would be talking about vitamin D, role of vitamin D in cardiovascular diseases. So all the sessions would be having a couple of talks, which would be followed by a panel discussion. And after the completion of 2 sessions, we would be breaking for a brief time for a high tea, which would be again arranged outside of the hall only. So now, moving forward, we would be directly, as Dr. Mohan said, we would be directly moving on to the first session. And this, as I said, would be discussing the role, the various aspects of hypertension. And for this, the drafting, the exact topics, the verification of presentation and the contents and everything. This session was mentored by Dr. Hilal Rathir, and he is again a known faculty. Everybody knows him. He hails from JNK, and he's a big cardiologist. He's a big name in JNK as well as across the country. And without the help and guidance of him, this would not have been of the quality which it is. So he would be the mentor of this session, and to chair and to mentor this session, I'd like to ask Dr. Hilal Rathir to come over the dais. And when he comes over the dais, I'd like to request Mr. Sambit Datta to invite him with a flower bouquet. Now, dais is yours, sir, for the context.
I am Dr. Hilal from Srinagar. I practice cardiology. I am professor and head of the department at Sher-e-Kashmir Institute of Medical Sciences. So I have been given this task of mentoring this first session on hypertension. So as we all know, there has been a lot of progress in the management of complications because of hypertension, like you have stroke, heart failure, coronary artery disease, chronic kidney disease. But unfortunately, hypertension remained where it was. I think it was where it was 20 years back. So a lot of drugs coming and being introduced in the market, but control is dismal. Almost less than 30% of the people know they have hypertension. And then out of those, almost 1/3 are diagnosed or put on treatment. And less than 1/3 of them have a controlled blood pressure. Blood pressure control is entirely different from diabetes. You have diabetes, whatever control you, it might be throughout, it might be 6, your HbA1c, but complications still come. 20, 25 years, 30 years, 10 years, different depending upon patients. But hypertension is one such entity. If you control it, and adequately control it, your risk is as good as a normotensive. So it is very important in our Indian context to do things like picking up hypertension, maybe from schools. We don't have, we have only surveys, what is the prevalence of hypertension, but we actually don't do anything to pick up hypertension, control, nothing has been done in that regard. So we have to have some novel approaches in India to pick up hypertension very early, because the cost of treating the complications of hypertension are very enormous. But the cost of treating hypertension may not be that, or picking up it early, or preventing hypertension, as Dr. Saab just now said, that around 2-3 crore people are suffering from hypertension, hypertension related or cardiovascular disease. So this is a huge population, and if we see 3 crore, and out of that only 10% is controlled. So this is a huge population, and what is the morbidity and mortality? So we have to have some novel approaches. And to talk on these topics, I'll first call my chairperson, Dr. Bashir Ahmed Naiku, to please take the dais. Dr. Madhu Shukla. Now I invite first speaker, Dr. Sadbir Singh. He'll be talking on emerging trends of triple drug SPC and hypertension. Dr. Sadbir.
Good evening, everybody. Thank you, Team Cadila, for giving me an opportunity for discussing on some aspects of hypertension. As sir, I've already said that hypertension is very common. The important thing is that most of the people, they don't know about hypertension. But over last 4 to 5 years, one thing positive with the COVID pandemic has happened, that almost every home has now their own BP apparatus available. So if we tell our patients about how to see the blood pressure properly, I think that we can close that gap of at least the first step of diagnosis of hypertension. And the next step of hypertension is the management of hypertension is with the medicines and with the lifestyle. With the medicines, the largest shortcoming is that in majority of the patients with single drug, with single pill, it is not possible to manage hypertension. So transition. So single pill combination is an answer in majority of such cases in the management. Single pill combination is that when two ingredients were managed scientifically to be packed in one pill or in one capsule. It's not like a mixture of two drugs randomly at a dose, because the chemists and biochemical scientists have to see that whether it is compatible to manage these drugs together or not. So it's a complicated science, and it should be followed scientifically. The drug product in which
two or more separate drug components, the active ingredients are to be combined, and that is the best thing which we can do to manage our patients. So we will discuss about what is the data of single pill combination other than giving the drugs separately. Single pill combination history is quite long, and right from the 1950s, various single pill combinations were tried, and it is seen that now over last 2 decades they are very common in our Indian market. The most common being the ACE inhibitors with calcium channel blockers, or ACE inhibitor with thiazide diuretics, and similarly with ARBs. And other combinations, in particularly in some particular special situations like calcium channel blockers and beta blocker combinations. Hypertension has in itself has lot of uh, uh, parts which are to be seen. As the first was discussed, the high prevalence, which is seen that in almost 40% of adult Indian population is having high blood pressure. The lack of appropriate diagnosis is the first step and the first hurdle in the management. Lack of appropriate treatment is the another step, and inadequate prescriptions, and we have to tell our patients that when they have to take the medicine, it should be during the same time of the day to maintain the best blood pressure levels. So the insufficient use of combination treatment is the reason of this, and that is the reason that we should use single pill combinations. For greater BP reduction has been seen with single pill combination as compared to monotherapy. And definitely, when we use two drugs, the control will be better, which are acting on two different pathways. And there is a small increase in hypotensive effects with the two drugs. And also the control is seen that better is the control, better are the complications related things related to the blood pressure. There are some differences in the adequate control of hypertension between Europeans and Americans. The Europeans, they stick to 130/80. The Europeans stick to 140/90, and Americans, they say 130/80. But in most of the guidelines, the target blood pressure should be less than 140/90, and for less than 65 year, 130/80 is adequate. And if more than 65 year of age, if person cannot tolerate 130/80 because of orthostatic symptoms, then only 140/90 is to be targeted. European Society of Cardiology guidelines also say that single pill combination are better, and they prefer two pill combination. And it is seen that in majority of the patients that single pill is better. And it is seen that the step one is in 2020 International Society guidelines said that the first step is to use the submaximal dose of two antihypertensive drugs, because this has a better antihypertensive effect with less of the adverse effects. And then we can switch over to either to the full dose of two drugs or to use the triple combinations. Similarly, in other guidelines, World Health Organization has also said that the single pill combination is better, but the data says that in all the sum of all the guidelines, that what are the specific indications when the monotherapy, in place of monotherapy, single therapy is to be used, particularly in patients who are not controlled with monotherapy, and in patients with in individual therapy in which there is a stage 2 hypertension. We know that in these majority of these patients with single drug, we cannot control the hypertension in these patients. So Indian guidelines has also said that majority of the patients, they need more than one agent for the control of blood pressure, and combination therapy in a single pill is encouraged for better compliance, and single pill are to be started at the early stage of management of hypertension, as it is seen that starting the control of hypertension in the very early stage also decreases the further incidences of complications of hypertension, and there is a better long-term control and better confidence on the control of hypertension. And it is same in the diabetes, that if we encourage our patients right from the beginning for the better control, then their long-term control is better. So in single pill combinations where we use different drugs, there we can target different pathways and different pathophysiologies of hypertension. And when we target different pathways, then definitely the control is going to be better. I need not to discuss the molecular mechanisms, as we are all aware of this. So as per the uncomplicated hypertension, the first step in a patient in whom the stage 1 hypertension, we can use single drug. But in patients who are having stage 2 hypertension, or in which with one single drug cannot be added, in that we can add on to another drug. As per guidelines, the first thing is either ACE inhibitor, ARB, or calcium channel blocker, and then to add a diuretic. But in this situation, the Indian situation is little different, that we have seen that in our patients, the sympathetic drive of hypertension is more. And in sympathetic, if the sympathetic drive is more, the patient is having more of the resting heart rate is high. In that case, is the beta blocker should be used as first or second drug in young hypertensives, as we have seen that the young hypertensive, the incidence is common in Indian population as compared to the Western population. Similarly, in CKD patients also, we have seen that in CKD patients, they are usually resistant to this single drug. In those patients also, the multiple drugs are to be used. And also these patients are, because of comorbidities and related coronary artery disease or CKD, they are already on polypharmacy. So in these patients, for better compliance, single pill combination is considered better in these patients. CV mortality, as we know that as the blood pressure increases with every 20/10 increase, the risk of complications and mortality of related to blood pressure increases. So it's better to manage it early. And for that, it has been seen that in patients with, if we compare the patients on monotherapy as compared to multiple drugs in free combination, means that multiple tablets or a single pill, it is seen that the control of blood pressure is better with the single pill therapy as compared to even we are using the same drugs with multiple pills. Commonly, our patients say that, particularly who get medicines from government pharmacies, that you have written us a medicine with multiple combinations, but I have been given the medicines as separate. So we have to encourage our patients that the single pill combination not only improves the compliance, but it also improves the CV mortality. Though if we compare the single pill combination with the free drug combination, free pill combination, there is a not much difference in long term, but initially the control is better and the results are better, and the reduction of CV events and all-cause mortality is significantly less. In the single pill therapy, it has been seen that with the red graph, that there is an better control of blood pressure in the early weeks and early days of hypertension, whereas the whereas this monotherapy with add-on therapies, they will take longer time for the control of hypertension. Similarly, the adherence of patient to the single pill therapy in multiple studies have shown that the compliance of the patient is better. So there is no doubt that better compliance and better blood pressure control will be there. As in the various randomized trials have also shown that the combination therapies of the ACE inhibitor and diuretics, or of beta blockers and diuretics, have shown there is a reduction in not only the cardiovascular diseases, but also in the other events, also in the incidences of strokes also. in the patients who are on the combination pills. And these trials have shown that the reduction is significantly there in the CV events when we use combination therapies as compared to placebo or as compared to single therapies. So there are various combination therapies are available and approved by agencies in India, and they are available. And we commonly, as cardiologists, we use the combination of ACE inhibitor or ARB with calcium channel blockers and diuretics. And with a single pill, we can control the blood pressure in these, and they are easily, readily, and cheaply available. So lack of efficacy in the several trials have shown that single pills are better. Difficulty to achieve the goals with two medication has shown that the multiple triple drug combinations are better. And there is always a inertia from the patient, usually while they are on their walks or sitting with their friends, that you are taking single medicine and my doctor is prescribing multiple medicines, and because of that the patients have an adherence inertia and they keep on omitting one or two drugs from their treatment kitty, and this leads to increase in the blood pressure and then the complications. So the three drug combination in itself is a solution to the problem of a large problem of hypertension in majority of the patient because of better synergic effects of the combining the drugs, and is a rapid BP control and less adverse effects seen with this. And in patients who have high class of stage 1 hypertension or in patients of stage 2 hypertension, in those patients we should start our patients with the combination pill, either with the dual or with the triple combination pill. And it is important that in our patients, when we use multiple drugs, we should, if the patient is having a sympathetic drive, then we should use more of beta blockers. And in the single pill therapies, in the randomized trials have shown the better cardiovascular outcomes that we have discussed in the previous slides. So from dual pill to single triple pill combinations, definitely there is it's a better combination, and we can control things better, and the combinations are pharmacologically possible and they are available at a very cheaper rates. The advantage of combination therapy is that improve compliance. There are better BP control and better efficacious control and less of the adverse effects, and they are less cheaper, and fewer pills improves the patient's inertia toward the treatment. So the triple drug combinations, they provide effective mean to achieve blood pressure control and a large burden of blood pressure in our society. They improve compliance, improve drug adherence, and reduction of cardiac and stroke in hypertensive patients, and with least of the adverse effects. Thanks for your patient.
Thank you, Dr. Sabir. Please be seated. Thanks, Dr. Sabir, for a thought-provoking discussion. So I would request now Dr. Arif. He'll be talking on resistant hypertension. Is it really resistant or is it physician inertia? Dr. Arif.
Good afternoon, everyone here. I'll be talking about the resistant hypertension. And So as we have just heard Dr. Sadbir talking about the control of blood pressure with various drugs, one question arises, and which has been in detail been described in last some of the guidelines issued, where it was discussed in detail how to measure the blood pressure. And that is one area somehow neglected in our day-to-day practice. The measurement of the blood pressure task is given to the either the nurse or the assistant in the OPD. And that is very important thing, that the person, whoever is measuring the blood pressure, should be educated, should know how to take the blood pressure, and what are the guidelines and what are the factors that influence the control, the measurement of the blood pressure. And so a lot of time when we see in the OPD, when the patient comes, when we check the blood pressure for the first time, the first reading is invariably pretty high. And then you do the consultation, you talk to the patient, listen to their apprehensions and pacify them. And then if you take the blood pressure at the end of the consultation again, the blood pressure has come down significantly. And so there is definitely a role of understanding the white coat hypertension, the pseudo hypertension, and the real resistant hypertension, how to differentiate it. So resistant hypertension is defined as high blood pressure 140/90 despite use of 3 or more antihypertensive agents of different classes, typically a CCB, ACE inhibitor or ARB, and a diuretic, and given at a maximally tolerated dose, and apparent treatment resistant hypertension, and the need to exclude medication non-adherence. Now, this is a very important part. A lot of time when you actually talk to the patient may not come forth with the admission that they are omitting the drugs. It is usually the other person from the family who tells you that he is not taking this particular medicine. And there is one more thing that we must be aware of, that a lot of time patients are buying medicines from the local market, and they might not be able to get a genuine thing. They might have been cheated somewhere. And so they have to be educated on that front as well, because a lot of time you are giving appropriate medication. And I'll just give one example. Once we went to Afghanistan and we saw that patients were on 100 and 150 milligram of metoprolol, and still the heart rates were very high. And then while talking to those people who are there, we got to know there is so much of spurious medicines in the market. So even these things about the reality of the ground situation, we have to understand and take into consideration. Then ensure optimal drug dosing, confirm out of the. Now, this is another concept, and that is the probably not a new thing now, but we all should be aware that the office blood pressure, the home BP, and the ambulatory BP monitoring, all three things have to be understood. And if the patient, we are taking the office blood pressure, then what is the office blood pressure and how it should be taken? Invariably, the guidelines say that you have to make the person sit comfortably in a chair where back is resting, arms are resting, feet are on the ground, at least for 3 to 5 minutes. Only then you should take. He should not have taken any smoking or tea in last half an hour. So a couple of things. The bladder should have been emptied. There should not be any anxiety in the patient. So there are a couple of things that have to be taken care of. So again, emphasizing the importance of the measurement of the blood pressure, that it should not be given to the least important person in the setup. And obviously the white coat hypertension is there. And the meta-analysis of data from 3.2 million patients has estimated that the global prevalence of true resistant hypertension is around 10%. And a study that was conducted in South India. So there they found around 11% prevalence. And the pseudo-resistant comprising the non-adherence to treatment and therapeutic inertia. This was pretty high. And then in a study done in a secondary case in Jaipur, they found around 19% incidence. Now, some of the characteristics, secondary causes, and contributing factors. So if you look at the first thing, that the demographic, the characteristics of patients with resistant hypertension, they are invariably old age patients. They are a lot of time obese, and more common about the Western population, the Black people. Excess dietary sodium intake is there, and high baseline BP, and chronicity of uncontrolled hypertension. So these are some of the things. And the first point, the old age, especially the more than 75 years of age. These days, when we sit in our OPD, we keep seeing these old gentlemen coming. And if you listen to them, then you will actually understand they are alone at home, and they are left with the gadgets, like the kids and the elders are. And this was a surprise to me, that when I talk to these people, because I was not able to understand why the BP is not getting controlled. And then I got to know they are watching so much of YouTube and WhatsApp, and the content they are watching is a lot of time scary, and it is disturbing them mentally. And so this was another thing, screen time. We have been talking about the kids, but not the elder people. And so this is another aspect. Then causes of secondary resistant hypertension, more common causes like primarily hyperaldosteronism and atherosclerotic renal vascular disease. And sleep apnea is another very common, very less addressed issue, and especially where you actually find nocturnal hypertension. And CKD obviously is there. Then drugs and substance that may cause raised blood pressure, like oral contraceptives, sympathomimetic agents, and NSAIDs, cyclosporin, erythropoietin, invariably given to these CKD patients, and steroids and cancer drugs. Then recreational drugs and herbal remedies are also there. Then concomitant target organ damage, diabetes, and atherosclerotic vascular disease, and aortic stiffening, and isolated systolic hypertension. Then uncommon pheochromocytoma, fibromuscular dysplasia, aortic coarctation is another thing. And whenever we are doing echocardiography, then that is another thing. All hypertensive patients, we must check this. Cushing syndrome and hyperparathyroidism. Now, what are the challenges with resistant hypertension? So the additional risk for cardiovascular events, Dr. Sadhvi just mentioned that every 10-20 degree of millimeters of blood pressure rise doubles the cardiovascular risk. So the resistant hypertension, the age more than 55 years, the Black people, obese people, diabetes, and chronic kidney disease. So these are additional things, and invariably they are coming in package. Now, evaluating for resistant hypertension. So confirm the treatment resistance. So office BP, systolic BP, diastolic BP more than 130, 80, and patient taking more than 3 antihypertensives, all at maximal doses or maximum tolerated doses. So if the patient is taking all these and the blood pressure is still high, exclude pseudo resistance, confirm adherence to the antihypertensive therapy, perform 24 hours ambulatory BP monitoring to exclude white coat hypertension. So ambulatory BP monitoring has come up a big way, and it's helping a lot of time understand what is actually happening. And screen for secondary causes of hypertension. And this list we have already just covered. And assess for target organ damage. So the fundus examination should always be done on the cardiac left ventricular function assessment, and renal proteinuria, microalbuminuria should invariably be checked, and ankle brachial index. Now, confounding factors in diagnosis of resistant hypertension. So non-adherence, measurement errors, white coat hypertension, treatment inertia, lifestyle factors, drug-related resistant hypertension, and sleep disorders, and pseudochromocytoma. Now, physician or treatment inertia. Now, this is something we must understand, that as a lot of time when the hypertension patient comes to the clinic and blood pressure is there, so same as with diabetes, we don't want the person to develop hypoglycemia. Same, we don't want the person to go into hypotension. So the physician feels that he should be starting with the smaller doses. And a lot of time when you have started with a small dose, the blood pressure remains higher side. So there is sometimes inertia in the physician. So the Phillips introduced the concept of physician treatment inertia as a failure of healthcare provider to initiate or intensify therapy when guidelines indicate doing so. So a lot of time guidelines actually mention higher doses, but in real life, people give smaller doses. And renal reasons for clinical inertia are patient characteristics, like older age group patients are there, people are scared to give them higher doses. Then if the lower life expectancy is there, multiple comorbidities, particularly psychiatric conditions, and patients who are near target, or if their blood pressure is nearly touching the target, so there also people accept. And so there are physician characteristics and factors that impact the patient-provide interaction. So difference in physician risk tolerance, ambiguity, and decision-making within the realm of uncertainty. When it comes to physician characteristics, the lack of knowledge about appropriate goals, high patient volume, and time constraint. Now, these last 2 points, again, they are very, very important, that the high patient volume, a lot of time people have a lot of patients, and there is a time constraint. These patients who just have hypertension, they actually need time of the doctor. You have to sit with them, you have to understand what is happening, and probably good counseling to change the lifestyle and understand what is happening, what is the stress level, whether in domestic lifestyle is okay or there is a stress, office stress. Even these things add so much to the increase in blood pressure and resistance to the blood pressure control. So unless and until we address all those things, we are not going to have good control of the blood pressure. And they are falsely labeled as resistant hypertensives. Now, clinical inertia over the long term affects BP control. The impact of therapeutic inertia on long-term blood pressure control, a Monte Carlo study design. The impact of therapeutic inertia during treatment initiation persists during long term. So if we have not started appropriately from the beginning, this inertia actually ultimately results in poor control of the blood pressure, and these patients are not able to reach the target. Now, patient characteristics in relation to the therapeutic inertia. This was more observed with the patients who have grade 1 hypertension and isolated systolic hypertension and who are having good compliance, or older age group patients. And again, there were certain patients who had very long history of hypertension treatment. So they were also not given much higher doses of medications. Patient characteristics in relation to therapeutic inertia. Antihypertensive was not modified in 16% of uncontrolled or treatment hypertensive patients. This therapeutic inertia seems to be associated with old age a longer history of prior antihypertensive treatment, a higher rate of good therapeutic adherence, and lower mean systolic. If there is mean systolic is also low, so there has been inertia from the physician side, and grade 1 hypertension and isolated systolic hypertension. And the commonest reason for this where the target BP is not achieved, the reason has been under treatment. And if we can see, the medication non-adherence is also there quite significantly. More than 30% of the patients have got non-adherence. So that is another important thing we must keep in mind. And inaccurate BP measurement, the fourth one block, that is again around 25% patients are having problem from there. So that also needs to be addressed. Now, therapeutic inertia is responsible for a larger chunk of patient with uncontrolled hypertension. So this we just saw in the last slide also, that on the part of the physician, if they have not started the treatment adequately, the target BP is not achieved. And here, if we see the elder age group population, 80 to 90, there is a significant difference, that if there is a difference between the inertia and the non-inertia groups, which means that the majority of the physician, they prefer not to give higher doses or adequate doses of antihypertensive to the elder age group. And if we see by distribution of categories of the systolic blood pressure in the uncontrolled hypertensives with and without inertia, then again, the near target people, there the problem is more. Now, various clinicians related factors were responsible for the uncontrolled hypertension. And one was the repeated BP reading will be repeated, and lifestyle advice was not given to the patients. The recent BP readings less than 140/90. So again, people will not be increasing the BP medicine. And stress during the visit to the doctor, choice of the patient, and frailty of the patient also. Elderly patients who are very frail, they are also not given much of the medicines. And if the BP is touching the near normal values, again, in this situation, the BP medicines are not adjusted. And then white coat effect is also there. Now, this is a difference between the triage and expert obtained blood pressure. So the patients who are coming to the emergency department, if you see, I was just mentioning in the beginning that when the patient is just reaching to the hospital, he's in some pain, either the blood pressure is high, but the apprehension of what will turn out to be the systolic and the diastolic, both the blood pressures are high. So the true resistant hypertension and the pseudo-resistant hypertension are also there. So we must understand that patients who are reporting to the emergency, they should be adequately handled. Blood pressure should be measured as per the guidelines. 37.5% of resistant hypertension patients were found to be due to white coat hypertension. This is another data we all agree. And current management strategies for the resistant hypertension. So exclude other causes, secondary causes, white coat hypertension, non-adherence. That is step one. Ensure low sodium diet, and then more than 6 hours of uninterrupted sleep. And there should be adequate diet control, weight control, and patient should be doing exercise. A lot of time we have not been talking about the exercise, weight reduction to these patients, and the BP medicines have constantly been upgraded. So we must give little more time to the patients talking and explain to them the importance of reducing the weight and doing the exercise. Then the third step is optimize a drug regime, ensure adherence. Different classes of medicines should be used judiciously. Maximally tolerated dose should be given. Diuretic type must be appropriate to the kidney function. Now, if BP is still not controlled, substitute optimally dose thiazide like diuretics. And if the BP is still not controlled, then MRA should be added. And if BP is still not at target, then now this step, they say that the step 4 and 6 are suggested based on the expert opinion. These steps should be individualized. And a beta blocker should be added whenever it is possible at this stage. And consider central acting alpha blocker, central acting beta blocker, and if not contraindicated, and consider once daily diltiazem if beta blocker is not tolerated. And if the BP is still not controlled, then add hydrazine and in combination with isosorbide monotrate. And if the BP is still not controlled, then substitute minoxidil for hydralazine. And if BP is still not controlled, which we as practitioners once in a while keep seeing, so consider referral to a hypertension specialist and or ongoing experimental. So like renal denervation was tried in last decade, and initial results were not very good. Again, the trial is going on and we are awaiting for the results. Prognosis of resistant hypertension, we can see that the death, MI, stroke, CHF, CKD is, and the total events are far more. Thank you.
Thanks, Dr. Arif. So the discussion continues. Who should check blood pressure, where it should be checked, and this we have been discussing for decades now. We are still not reaching anywhere. But what I personally, at least personally, what I am doing in my clinic is that I have almost stopped checking blood pressure in the clinic now. I ask everybody, don't take mutton for 1 week, 1 day. Get a blood pressure machine for 600, 700 rupees. Please check blood pressure at home and get you the record. And everybody cannot afford ambulatory blood pressure monitoring. But I have started succeeding in some situations where we had patients, their blood pressure were never controlled. And then once I check their home blood pressure monitoring, that is adequately controlled. Thank you, Dr. Arif, again. Now, there will be a panel discussion. It will be moderated by Dr. Madhu Shukla. Dr. Madhu Shukla, over to you, madam.
So it will be a nice discussion. Hello. So this is going to be a very nice discussion, very light also. And there are certain questions we are going to ask our speakers. First of all, I'm going to ask Dr. Satbir, what is the implication of elevated blood pressure in low and middle income country populations?
In Indian setup, as in lower middle income countries or in middle income strata, we have seen that the blood pressure and associated comorbidities are more in the younger age group, because blood pressure start at the younger age group. So the working years lost are more with the complications of blood pressure. So the impact of blood pressure and the cost effect of that is much more in the middle income strata as compared to the Western world.
Okay. Yes. Dr. Mohan, would you like to say something?
I think the issue is clear that, and it was actually clearly brought out by Dr. Satbir and of course our mentor. The fact remains that the last or the fourth National Family Health Survey from India, published in 2019 in Public Library of Science, suggests that only 7.9% of all hypertensive in India have controlled blood pressure. 7.9%. When you compare this with the high income country like United States, it is 55%. So the thing is obvious. Multiple reasons are there for this kind of poor control in low and middle income countries. And we have actually, some we have discussed. And I think there may be, actually it was clearly mentioned by our mentor, Dr. Rathar, that the basic issue is not knowing you are hypertensive, then not being treated for hypertension. Even if you tell me I am hypertensive, I go to you, I'll say, no, aaj maine 2 chai zyada pi li thi. I don't want to take a drug. Our attitude has to change. Physician's attitude has to change. Patient's attitude has to change. Society has to look at blood pressure in a different way. How have these people been able to achieve 55% control in US and we are at 7.9%? We have much cheaper drugs. There is no doubt that the single pill combinations in India, as Dr. Satbir Singh said, are much cheaper in India actually. They're easily available. This is true that government dispensaries still don't give SPC. We just have to actually convince the powers that be that you should let small dose of 3 drug combination come up in those things, especially in the Prime Minister's program of Jan Aushadhi and other things. That those are really the effect. But there is no doubt that lower and middle income countries are having the greatest burden of complication hypertension because of several reasons. Our wrong policies, awareness, control, everything which has been discussed by our mentor in great detail, and of course both the speakers. What can we do? Difficult to say. Actually, first is, of course, at every opportunity, get the blood pressure checked for the people, whether they go to attend, getting into the mall, getting into cinema theater, going for a mela, going for a fair, a religious party, temple, mosque. Put a BP, automatic BP apparatus actually. You put your arm, blood pressure comes up. At least the person will know that my blood pressure is high. He or she will try to get the blood pressure down. This is a much cheaper way of increasing the awareness, and that is not being done actually. As far as the drugs, the control is concerned, of course, the SPC is the way to go forward. In this country, howsoever you may try, the only way to go forward SPC. They are much cheaper, they are generic, so you would have to. With regard to control will come automatically. So we need to have will actually, and of course, as both speakers said, inertia. There is a tremendous inertia we all have got. But I would completely agree with Dr. Rathar that the important thing is let the patient bring home blood pressure recording. Those are much more reliable than office blood pressure readings. So that the so-called resistant hypertension is not that much. Actually, probably is in the range of 10%. Probably in the range of 10%, not more than that. Mostly because we are aging, we have more diabetes, we have more kidney disease, we have more obesity, and our salt intake is more. Forget about stress and pollution. We don't talk about that. But the moment we start talking about this, it becomes generalizable. It becomes non-generalizable, but the fact remains that we have those issues. So that would be my way of looking at this first question.
I think it's very important because that constitutes the major population. And that is where it is they are hit the worst. If that social class has a complication, stroke, renal failure, anything, and that is for them, it is very difficult to manage them. And second, one thing I have to be emphasized, many of our patients still have a concept or have an idea that blood pressure measured by a doctor is always better. And sometimes they don't give equal weightage to the readings on either side reported at home. So that was high, but it was at home. So I think if you are measuring it correct, so that is more likely to be correct. So if it is happening frequently, if somebody has those higher or lower readings at home that are equally reliable or more reliable, and that's very good concept that, if there is, it's very likely that if somebody buys a BP monitoring machine, he will measure it, number one. And number two, if he's hypertensive, he will follow the lifestyle measures more strictly than others.
But Dr. Dr. Lal said something which actually has touched my heart. We can tell people, please do not go to eat out once a month and buy a BP operator. That would be much better way of actually helping people.
No, I would agree with Dr. J.C. Mohan fully that home blood pressure monitoring, I have found in my practice the best way of identifying hypertensives. Depends on how you are checking the blood pressure in the clinic. When we used to see 80 patients in 3 hours in government hospitals, OPDs, everybody's blood pressure used to be normal. I still remember, it takes time for you and me to check blood pressure. And I wish, many of us wish that we have that kind of time. I convince my patient 200% that digital method is the only correct method of checking the blood pressure. Because, digital instrument doesn't recognize whether it is arm of Prime Minister or arm of you or arm of some. So maybe once or twice they are confused, but then few readings onwards, they are convinced that the best way to check blood pressure is at home with the digital instruments. And they are very, very accurate. See, why are they not accurate? Because you don't tell the correct way of answer to the patient to check. You have to specify it 5 times at least once, that don't move your arm, don't jerk your arm during checking of the digital instrument. You slightly jerk the arm. It's not sensitive chip, it's a hypersensitive chip, which immediately records whatever you move. So, these are the things which I think the home blood pressure monitoring should be, as you said, miss 1 meal in a month and buy the instrument. That's a ideal way of, and of course, all of us tell the patient the most common symptom of blood pressure is no symptom. Most common cause of blood pressure is no cause. Don't waste your time in searching the cause of the blood pressure. Presume that every hypertension is essential hypertension. Those secondary hypertensions are so rare that they will automatically come forward someday or the other. You will be able to judge it. But then don't waste money and time to find out the reasons for it.
Yes, Dr. Madhu. Let's quickly go through 1 or 2 more and then we go on to the next one.
Okay. Do we need to have novel approaches in managing hypertension in Indian scenario, and why? Dr. Arif.
Novel approaches.
Indian setup, it's very poor. People are not aware of any term called hypertension. And then they don't have facilities. They have to work hard for them. They can't think about everything else. So we have to make these people aware of. There is some entity called hypertension, and they have to deal with it, which can lead to severe consequences in later life. So what can we do? How to teach them in a simple way? Like there are gatherings, social gatherings, political gatherings, and then there are churches and mandirs, temples, where people are collecting. Our government can approach to provide the BP instruments and check the BP of these patients, give them knowledge that there is BP, an illness in the later life which can cripple you and consume all of your income. So another thing is, if their people are slightly educated, you can give them some knowledge, some pamphlet, or you can give some way to read and know more about this. These are things you can do for Indian scenario. First of all, Indians have to be made aware of things. Second thing is Indian diet, which is full of salt. We like pickles, we like chips, all these things, they have a high salt ingredient. So that is one thing which has to be cut down. Third thing is we have to change our food style. We are eating more oily, more fatty, more carbohydrates. We need to include more vegetables, more fruits, and more high protein. These are the basic things which can be easily taught by the government and by private associations to educate the people so that they can learn and have benefit of this. Anybody else?
National campaign on salt reduction.
Yeah, but Dr. Arif, any other novel approach we can use?
Sir, I think educating our doctors at the periphery That is very important and very essential.
But I mean, yeah.
I just want to say one word.
Yeah.
See, we all are part and parcel of WhatsApp groups. And everybody is spending, somebody just now mentioned that even elderlies and retired and not working are also seeing the WhatsApps. Why don't we as a physicians and cardiologists think and devise one or two messages with the small stories highlighting measurement of the blood pressure, its importance, and trying to remove the taboo that once somebody has got high blood pressure, he is unfit for everything on anything. Possibly that will go a long way. And Cadila Pharma is a huge company. We can request them to make some small graphics, small WhatsApp things, which can be circulated down. And we as physicians should say, at least in one group, I'll send at one message regarding blood pressure daily. Thank you very much.
I think this is, sorry, yes.
Most companies, many companies are providing that you can scan the code and there is a chatbot who you can talk and all answers about hypertension can be given. The only problem is it will apply to educated people and a large population. You and me, the problem with you and me who live in cities think everybody like us. Unfortunately, not so.
That's why I said in all the groups that we have got family
Yes,
group,
WhatsApp, yes, this is a novel, one of the very novel approaches. But I'll tell you, sir, in Kashmir, we had a problem. People would develop acute myocardial infarction. And then we undertook a study. We want to see where is the delay? Why is the delay in getting thrombolysis? And believe me, 30% of the times it was doctor inertia. They were scared of giving. So what we did, we created a group called a Save Heart Initiative. The Save Heart Initiative was that all doctors in periphery, district hospitals, sub-district hospitals, we connected to them with this Save Heart program. That whenever you have a acute chest pain patient, just upload the ECG.
Great.
Somebody will, yes, yeah. And this will go to the group. Somebody from the group, he will see this, he will tell the advice there and then what has to be done. And believe me, sir, most of our patients, they come from Ladakh, they come from Kargil, Doda, Kashtwar. They are all thrombolized, and once we do their angiography, almost this initiative
my
got
kudos for you.
This initiative got Save Heart Initiative got a state award also.
Great.
So most of we undertook a study and we are finding that most of their coronaries or infarct-related arteries are open.
Yeah, Dr. Mohan, talking about hypertension
because it's a timely approach
for this symposium. See, we all talk about salt, exercises, losing weight. Everybody knows the benefit. I think most of the patients know. You don't need to tell them that salt and weight and all these things help. But has it really helped over the last 30 years of my practice? No. So what I do in present scenario, I get high blood pressure in a patient, even first reading. I tell them to start the medicine. Yes, if you lose 5 kg, your medicine is going to come, the dose is going to come down. If you lose 10 kg, I am 50% hopeful that your medicine will be stopped. But start medicine today. See, there is no simpler way of controlling blood pressure than pharmacological medication. Reducing salt, losing weight, controlling OSA, it takes them 6 months to arrange for a BiPAP. So, all those things should be simultaneously told, but please start medicine on the first day. As soon as you start the medicine and you emphasize that you must take the medicine, patient is partly scared that आज तो medicine शुरू हो गया तो मुझे weight कम करना ही करना है, मुझे salt कम करना चाहिए. If you don't start medicines, they won't comply with the non-pharmacological methods.
Thank you very much, sir. If we start discussing it, it will end.
We need to go forward. And hypertension will always excite these kind of things all the time.
I think, sir, we'll conclude this session. Thank you, everybody. Thank you, chairpersons. Thank you, moderators. Thank you very much. Over to you, sir.
Sorry for interruption, sir. Actually, I would like to ask you regarding the more villager people, sir. Villager people are asking about whether they have tricks, like some like 250 है क्या करें, कुछ होता ही नहीं है, Because nothing understandably I was resistance hypertension.
No, problem is what I personally feel, sir. Dr. Saab has already said this, that you install blood pressure machines at every nook and corner. My personal opinion is that we should start it from schools, because you start it from schools, go to colleges, go to universities, go to where big construction work is going on. You have a lot of labor force there, check blood pressures there. I am 100% sure that we'll be able to cut it somewhere, we'll be able to get it down. But it needs a concerted effort. Thank you.
Sir, my last question for my side. Any update about the ambulatory blood pressure monitoring in the white coat hypertension, resistant hypertension, or mask hypertension? Just wanted to know a few lines by the speakers.
So the ambulatory blood pressure monitoring should be done. Yes. The good news is that simpler methods are coming for ABPM. All they have to be verified. These have to be made robust, tested and retested and verified. But I'm pretty sure that in 5 years' time, we would have verifiable, reproducible readings of 24-hour blood pressure. Maybe in our watches, maybe on bands, maybe on fingertip, maybe on rings, something will come through. At the moment, it is available. The equipments are available, but the only issue is, are these verifiable? Are these reproducible, robust? That is the issue. So a lot is happening, but the currently, otherwise ABPM you should use, but the only problem is, despite we having tried for last 20 years with ABPM, use of ABPM still is dismal at all levels. Obviously, inconvenience is there.
The practical question. Basically, in your practice, you know that Narcos has more is respect competent towards it. But the incidence of hypernatremia in your day-to-day practice, how often do you find hypernatremia, which is a very dreadful complication, which we have seen in our day-to-day practice?
Both drugs cause hypernatremia. More in elderly people, and more once you exceed the dose of 6.25 chlor and 12.5 of hydrochlorothiazide. It is an issue. We can't brush it under the carpet. It occurs in 5% of all population and 10 to 20% of the elderly people. Many people believe that we have taken the story of salt too far. And we need to actually be liberal with salt in some of these people. So this itself is a very interesting thing. A lot of work, reworking going down, being done in salt. You must have read sodium HF study. And there was another study which said, if you just don't restrict sodium in acute decompensating heart failure, patient improve faster, their renal function faster, they're out of hospital faster. So a radical change is occurring in our thinking. But we are not going to discuss that because otherwise it will be whole night sitting here.
Thank you. Thank you. And I would thank Dr. Hilal as well as all the faculties for such a nice session. And this happens like topics like hypertension. These are such vast and interesting topics that we normally go ahead with multiple points and discussions. But now we have to move to the next session. And the second session, we would be talking about dyslipidemia and the related aspects. And for that, there was a great help and great mentorship that we received from Dr. Rajiv Rajput, sir. And he is again a known faculty across the country. And without his guidance, this would not have been possible to draft and formalize this session, particularly the dyslipidemia. So without passing any time, I'd like to invite Dr. Rajiv Rajput, sir, on the stage. And for that, I'd ask our president, Mr. Samit Datta, to welcome him. Now, I would hand over the dice to Dr. Rajput and would ask him to grace his words.
Good afternoon.
After this wonderful discussion on hypertension, we next session will be on dyslipidemia. And I think all of us have seen the tremendous improvement and change in our understanding how we look at lipids and how we treat them in last few decades. As Dr. Mohan said in the beginning, number one killer, coronary artery disease. Number one predisposing factor, dyslipidemia. Among the dyslipidemia, the most important modifiable factor is LDL. And the drug which has caused tremendous improvement in control of LDL and improvement in clinical outcome is statins. We are using them for last many decades, right from secondary prevention to intensive treatment, high dose statin to primary prevention. We have robust, randomized, large-scale trials which have proven beyond doubt the role of statins. It is not surprising that if you see the first few trials, the LDL level achieved in the treatment arm was more than what is the inclusion criteria in most of the contemporary trials today. So that has been the change in our understanding of LDL and how much it should be lowered. Along with that, there has been a lot of concerns about using statins, especially with social media coming up and being very popular. Side effects of statins, not required, commercially available angle, and then they cause diabetes, they cause muscle symptoms, and then they cause new onset diabetes, and they damage your liver. And it is not surprising, many of your patients asking in your clinical practice every day, are they harmful? Or in other way, how harmful they are. So that's one aspect. And second is that all? Do we need something beyond statins? Do they take care of all our atherosclerotic disease risk as much as possible? So these are the two areas which we'll be discussing today. With that, I would like to invite our chairperson, Dr. Sidana. Dr. Sanjeev Sidana, please. And our moderator, Dr. Giridhar. Okay. So we'll have two short talks. First will be by Dr. Ashish Singhal, and he will be discussing about adverse effects of statins, myth or reality. Please come. Dr. Giridhar, please come. Please join us. And the second talk would be residual inflammatory. I think it's more than inflammatory. It should be residual atherosclerotic risk even after statins. And that will be by Dr. Rakesh Verma. So with this, I like brief comments from after the talk. So I'll request our first speaker, Dr. Ashish, to present his views on adverse effects on statins, myth or reality.
So good evening all, and thank you. And right, without wasting further time, I'll be straight away going to the topic of today's discussion, which will be adverse effect of the statin. It's a reality or a myth, how to tackle it. So we all know statins are the most common drug which has been proven to reduce the morbidity and mortality worldwide in the field of coronary artery disease and stroke. Statins are the most commonly prescribed drugs for the prevention and management of dyslipidemia. They have immense therapeutic benefit, though there are some side effects which we are going to discuss. So how does the statin act? It's mainly act by inhibiting HMGA, which is hydroxymethylglutarate coenzymic reductase inhibitor, so that the cholesterols are not formed. And it helps in prevention, both primary as well as secondary events. The treatment with statins, which lowers the bad cholesterol, mainly LDL, reduces the all-cause mortality by 10%, and the major cardiovascular events by 25% for every 40 milligram deciliter reduction in LDL levels. Even when the LDL cholesterol levels are lowered by 1 millimole per liter, the stroke reduction is almost 20%. So this is a small flow chart which is showing that how does the statins act. So basically, it inhibits the HMG coenzyme A so that the final product of the cholesterol is not formed. They also have a pleiotropic mechanism by acting over the liver so that the squalene is not deposited in the peripheral tissues. Also, at the cellular level, it promotes vasodilatation, anti-thrombotic effect to a certain extent, and prevents addition of the molecules and release of cytokines. Now we discuss the side effect and safety profile of the statins. We all know that the statins are well tolerated by most of the patients. However, the adverse effect of the profile statins includes statin-induced myalgia and myopathy, a transient elevation in liver enzymes, new-onset diabetes, increased risk of acute renal failure, cognitive dysfunction, or memory loss. There are more side effects, but they are very rare, which we are not going to discuss in detail. So, as Sir already mentioned, that there is some sort of side effects which has been impregnated into the minds of the patients by media and certain articles, which we are going to know that how serious they are. This also creates a doubt in the minds of the physician that whether the statin dose should be increased even without achieving the target LDL cholesterol level or not. Also, most commonly, the physicians have inertia in prescribing more potent statins because of these side effects. So what are the adverse effects of the statins? At the skeletal muscle level, it causes myalgia, myopathy, and rhabdomyolysis in the order of severity. Liver injury by elevation in liver enzymes, SGOT and SGPT. So, to some group of patients, there is some elevation in blood glucose levels causing a new onset diabetes. Kidney injury by rhabdomyolysis, cognitive dysfunction by decrease in memory, and cancer, which is very rare. So the most common side effect which is experienced by the patients includes a benign myalgia. So a muscle pain without or an increase in CK levels is usually seen in patients who are taking statin in up to 3 to 5% of patient group. This is more commonly seen if the patient is on high dose statin up to 10%. Statin myopathy, which is defined as increase in creatine kinase level more than 10 times, is very rarely seen in patients who are on statins. Most commonly, it is not diagnosed because the patients are not getting themselves tested. And also there is inertia at the physician and cardiologist level in getting this CK level done. Rhabdomyolysis, which is an extreme complication of the statin-induced myopathy, is characterized by acute renal failure and a severe elevation in CK levels in between 10 to 15 times from the upper limit. It is usually seen in 1.5 patients per 10 million of the patients. So how to define these skeletal side effects? Myalgia is not associated with CK levels elevation. It is a simply characteristic the patient complains of pain or weakness. Myositis, it is defined with elevation in creatine kinase levels. Rhabdomyolysis, where the creatine kinase level is associated with myalgia and the levels are more than 10 times. Now, to characterize the hyperCKemia, we can define into 3 categories: mild, moderate, and severe. Mild can be again classified into grade 1 and grade 2 from less than 1 to more than 1 to 5 times. Grade 2 is more than 5 to up to 10 times. Moderate is between 10 to 50 times, and severe is more than 50 times. Now, what is the mechanism of causing myopathy? There is a reduction in the coenzyme Q10 levels. There is a vitamin E deficiency in the patient, and a sarcoplasmic cholesterol reduction is also seen. The usual factors which predisposes a patient for increased risk of development of myopathy includes an elderly patient of age more than 80 years, female gender, a low body weight or low muscle mass, patient with already on renal or hepatic insufficiency, patient having hypothyroidism, a perioperative period where a nutrition requirement is the patient is more, and a genetic polymorphism causing more hepatic uptake of statins. Hepatotoxicity is usually characterized by asymptomatic rise in SGOT and SGPT levels. It is usually seen in up to 2% of the patients. Multiple mechanisms has been quoted like bile acid transport, proteins impairment, inflammatory response, cytochrome P450, and oxidative stress related mechanisms. Most of these elevations, they resolve spontaneously when the statins has been withdrawn or reduced in dosage. Usually, the hepatotoxicity is most commonly seen with atorvastatin and simvastatin in high dosage. New onset diabetes. Now, there are multiple articles where we have heard about that the statin causes a rise in blood glucose level causing development of diabetes. However, the incidence is more where the patient is already predisposed to the development of diabetes, particularly those who are overweight and obese with a sedentary lifestyle, active smokers, and dyslipidemias. And a high dose statins usually increases the blood glucose level to a certain extent. The mechanism includes a decrease in insulin secretion by a calcium dependent fashion. Also, it inhibits the GTP binding proteins so that the action of the insulin at the peripheral tissue level is reduced. So the statins significantly reduce the cardiovascular risk. However, the risk of the causing diabetes is also there, which is quite low in comparison to the benefit of given by the statins. Effect on the kidneys. As already mentioned, rhabdomyolysis is one of the cause which can cause a renal failure in patients with who are on high dose of statins. There are certain studies which have shown that the kidney injuries related hospital admissions has been caused by high dose statins. Especially it is seen within the first 4 months after initiation of the drug. The exact mechanism is unknown. And in the Jupiter trial, a non-significant increase of 19% rise in acute renal failure was also seen. Cancer, there are certain cancers, particularly in pancreatic cancer, has been reported to be associated with the statins. However, meta-analysis of the multiple studies has clearly shown that there is no definitive evidence to conclude that the statins causes cancer of any type. Cognitive dysfunction. Previously, in some studies and as per our old teachers, they used to say that the statin causes cognitive dysfunction, memory loss, particularly in elderly and with those with causes early onset Alzheimer's. However, this has not been proven in multiple randomized trials of meta-analysis that statin does not cause cognitive dysfunction or memory loss, no matter how the LDL is going down. So if we discuss statin intolerance, it can be categorized into two parts. One, where the goal of LDL is not achieved because of the intolerance of the statin adverse effects. And two, where the goal is not achieved because of the impotency of the statin, which we call as goal inhibiting statin resistance. So what are the factors which causes more statin associated adverse effects? We all know, I'll just enumerate them in brief. Elderly age, female sex, Asian ethnicity, a low BMI, history of already pre-existing muscular or neural disease, history of CK elevation, a family history of myopathy, severe renal disease or liver disease, patient with acute decompensated heart failure, hypothyroidism. Some neuromuscular diseases like myasthenia gravis, myotonic dystrophy, neuropathy, and genetic polymorphism also predisposes to the patient to develop statin-associated adverse effects. Exogenous factors, the other outside our body, like high statin dose, alcohol intake in exuberant manner, enzyme inhibitors, particularly cyclosporine, azole antifungals, large quantities of grapefruit juice or pomegranate juice, patients who have undergone a recent surgery with a severe metabolic demands, patients who are going under heavy exercises, other drugs, particularly antipsychotics, fibrates, amiodarone, verapamil, polypills, or nicotinic acids also contributes to the statin-associated adverse effects. So these are the certain drugs which we are commonly prescribed and which leads to more drug interaction while prescribing statin. We should be more careful while prescribing them. Suppose the patient is all antifungals, then the simvastatin and lovastatin are contraindicated. We have to decrease the dose of atorvastatin and fluvastatin to 20 milligram. Macrolide antibiotic, which is an enzyme inhibitor, again is contraindicated with simvastatin and lovastatin, which is mainly CYP450 dependent metabolism. Other drugs like colchicine, cyclosporine, digoxin, gemfibrozil, niacin, one should be more careful while prescribing them along with statins. So what principles we should follow if the patient develop intolerance to the statins? So some questions we should ask that, is there an indication of the statin therapy in the patient? If the patient already have a features which limits the use of statin in that individual, is the statin indicated is for primary or secondary prevention? Does it can develop a nocebo effects? Is the patient having a dietary weight or exercise goals included in the plan? If the patient have a systematic challenge, de-challenge or re-challenge occurring after the failure in achieve the target goal, and can we use a non-statin therapy to achieve the therapeutic goal? So before prescribing statin, one should always get these tests done, particularly our lipid profile, HbA1c levels, fasting glucose, LFTs, and KFTs, even including albumin creatinine ratio, thyroid profile, and a ECG along with the creatinine kinase. So even on follow-up, these investigations should be repeated as per the patient's symptom, but it is advisable to compare with the baseline, not to do at the first follow-up at first time. So what to do once the patient develops a myalgia or a myopathy related to the statin? So if the patient has a CK creatine kinase which is below the normal limit, we can stop the statin, reassess the symptoms after some time, and give patient to recover and come out of these symptoms and restart the therapy at the lower dose or with different statin, and we can see response to the drug. If the patient is having a documented creatine kinase elevation which is above the normal limit, if it is more than 10 times, it should be stopped immediately. We should consider and look for the predisposing factors which we have discussed previously, treat them, remove them, and once a patient CK levels have recovered to the normal limits, the statin should be restarted at a lower dose, or we can also think of starting a non-statin lipid lowering drug. If a CK levels is below 10 times, which is under mild hypercemia, similar things should be done, but this time we can use the same drug or even try to switch into the other statin group, not starting with the first statin that we've used in the first time. Even after this, the patient again recurs the symptoms or redevelops, and we have to measure CK levels again. If the CK levels are within the normal limit, no further testing is required. And if the CK levels are elevated between less than 5, again, therapy should be continued at a lower dosage, reassess the symptoms within 6 to 12 weeks, and restart the drug and continue the drug. If the patient CK levels are between 5 to 10, statin should be stopped, eliminate or remove the predisposing factors. We should start statin at a lower dose and monitor symptoms and enzymes in within 3 to 6 weeks. If the levels are again more than 10 times, statin should be stopped completely. We should look for the rhabdomyolysis. Urine myoglobin should be assessed. Rehydration should be warranted in case of renal dysfunction. And followed by 6 to 12 weeks, we can consider referring to them to a specialist or start in a non-statin lipid lowering drug. So if the patient has developed a liver enzyme elevation after the statin therapy, what we can do, we should see what is the transaminases elevation level are. If they are less than 3 times, then no further testing is required. We can just wait and stop the drug and give time to the statin effects to wash out and see the enzyme levels are coming down. If the statins is causing the transaminases elevation more than 3 times and patient is symptomatic, statin should be stopped immediately. If the patient is asymptomatic, we can stop statin, reassess the symptoms within 6 to 12 weeks, and depending upon the enzyme aminotransferases level, we can start the statin at the same dose, lower dose, or consider switching it to the other statin. And after 3 to 6 weeks, we can reassess these symptoms. If we see the other conditions of the liver, what the effect of the statin is. So in hepatitis C, it is not does not cause much of an elevation in transaminases. Rather, there is a decline in transaminases level and improvement in the hepatitis C virological response. Even in NASH, there is an improvement in the transaminases level with improved steatosis, primary biliary cirrhosis, autoimmune hepatitis, liver transplant patients, and alcohol consumption. They do not produce an increase in aminotransferases after statin initiation. So even with patients with these conditions can be safely started on statins without much of a concern. So if a patient has a goal-inhibiting statin intolerance, we can give a trials of atorva and rosuvastatin depending on the requirement and potency of the drug what we require. If the patient has a partial or incomplete tolerance, we can either switch the drug, atorva to rosuva or rosuva to atorva. And if the patient has a partial or complete intolerance to the atorva or rosuvastatin, then we can switch on to the other drugs. If the LDL cholesterol level is within the 20% of the goal, we can add ezetimibe. And if it is more than 20%, we can start adding in sequential manner ezetimibe, niacin, resins, PCSK9 inhibitors, lomitapide in case of homozygous familial hypercholesterolemia, and apheresis if available, and a complex polypharmacy which can also include blood sugar lowering medications if the patient is diabetic. So this is a checklist form, what we can do and should utilize while prescribing statin. What is the indication? What is the baseline LDL cholesterol level is? What is the treatment goal we are targeting? What is the unavoidable drug interaction patient is going to have? Is there any comorbid condition? And what drug we have prescribed in how much dose? And what measurements we have done on baseline and follow-up. So the management includes of the goal inhibiting statin intolerance. Step-wise is ensure the patient has a valid indication for the statin therapy. Identify the factors which reduces the usage of statin and treat them. Ensure the patient is informed regarding the benefits and risks of the statin. We should encourage the dietary interventions and exercise along with the statin prescription so that the patient do not go on fasting or much of an exercise which reduces the muscle mass. We can utilize a systematic challenge, de-challenge or re-challenge approach on periodic basis. And if necessary, we can switch to a non-statin lipid lowering regimen. Thank you so much.
Thank you, Dr. Ashish. I think we had a very detailed discussion. We will come back again and discuss few points in brief after the second talk. Now I will invite Dr. Rakesh Vermaji to give a talk on the residual inflammatory or atherosclerotic risk after statin therapy.
Friends, delegates, colleagues, respected Dr. J.C. Mohan, Dr. Sunil Modi, my friend Dr. Rajput, Dr. Chandra, and Dr. Gupta and other colleagues. Today, as I've been seeing, a lot of discussions are going on hypertension. Now, some discussion is coming on the statins. A lot of people are very young, and you will realize that the concept of statins came something about 45 to 50 years back, when a lot of reports from WHO and other international bodies started coming and blaming that So some 50 years back, we started thinking that possibly the Indian diet is so bad, or the diet for this area is so bad, that everything was blame was being put on that diet. That we are eating, as some of the people, some speakers also mentioned, that we are having more of fats and we're lethargy, we're not working. But Dr. J.C. Mohan made a very good comment that we are not that rich a country, although he was saying in the context of hypertension. Friends, you remember, he said that because we are not financially that sound, Dr. Modi also put in his comment, and that's why our hypertension controls are not good. I usually ask, if India had some 40 years back, 90% population below the poverty line or in the moderate or poverty range, how much we can consume? You all are attached to the ground level. The fats are the costliest thing in this country even today. 1 kg of atta when I was a student was costing 2 rupees. Today it's cost 50 rupees. 1 kg of sugar is costing only around 45 to 50 rupees. Luckily, I'm not required to purchase. Somebody else purchases. But if fat is still about 200 rupees per liter, Desi ghee is touching almost 1,000 rupees. So how a rickshaw wala, a auto taxi driver can purchase that much fat to consume? He makes it very difficult to meet the ends meet. However, in our emphasis, because our genes were of a different nature, that's why we had those high levels of the cholesterol or LDL cholesterol in our bloods. The investigations are proving. Now, in a competition among the cardiologists, physicians, treating doctors, we starting doing more and more use of statins. Once we start using more and more of statins, possibly their bad effects had to come. I do not know of a single allopathic medicine which doesn't have a side effect. And if we give more in amount, possibly the side effects are more. Simple aspirin, tablet of aspirin, we started from 325 milligram, came down to 65 milligram. GRASA came for 50 milligram. Now the dose is hanging between 75 to 150 milligram. But if you remember, when we were treating rheumatic heart disease, we were giving patients 18 to 30 tablets a day depending on the body weight. And the patient was developing gastroenteritis. Now, the concept among physicians and cardiologists was that keep on increasing the dose of statin that you're giving. And, as much we increase the statin, the benefit is more. Some Inas and Inas came some 4 or 5 years back in Delhi. He gave a lecture. He said, 0 LDL is the best LDL. The concept started from 120 to 100 to 80, 70, not 60. Possibly they really want to bring it down to 0. And everybody says the more the statins, the better it is. Lower is the good, lowest is the best. There's a beautiful slide just now. Lowering LDL cholesterol to very low level is safe because they said there's no side effect. Even below advisable level, you bring down it, it becomes the best. So how to attain that levels? By increasing the statin from 5 milligram now as much as 80 milligram per day is being recommended. When you give 80 milligram of statin, what will cause? It may bring down the LDL, but definitely going to give rise to a lot of side effects, patient dissatisfaction. And my predecessor has been very, very kind, and he has taken away a lot of my burden in telling there's not a single system except hair, which you mentioned, did not mention, which is not being affected by the statins. Would somebody help me out? What is the other body part or system which is not being affected? If somebody tries, possibly the baldness or whiteness of gray hair could also be attributed to heavy statins. But this was going to happen. This was almost going to happen. And the statin therapy is associated with the reduction in the cardiovascular risk in patients. To keep on increasing the statins, keep on doing for longer times. At 75 or 80, when it's time for one to rest and relax, but they want to give a 80-year-old man also more life, whether he's on both crutches or on a wheelchair, to keep on dragging himself in the society, but keep on having the statins. So we as a physician and cardiologist have to look into introspect ourselves. What we are going to do, what we are doing. Are we totally correct or possibly like to modify? That is one aspect of the story. So friends, the biotechnologists, pharmacologists, and even physicians started looking for other areas. How can they keep on LDL being lower and lower and lower, but at the same time, avoid the statin intolerance and the so-called inflammatory or side effects of the statins. Obviously, if you want the LDL to be low, you want total cholesterol to be low, if you want triglycerides to be low, certainly you have to find out some new means. We are getting lesser of fossil fuels. We are getting, petrol was getting costly, diesel was getting costly, coal was getting inexpensive. The environmentalists came कि साहब कोल खोदने से तो environment पूरा गंदा हो जा रहा है, पराली जलने से तो दिल्ली वाले मर जाएंगे, तो कुछ ना कोई और रास्ता निकालना था. What are the other ways? Non-fossil. First started with solar. Then the pavan chakkis. If you go to Gujarat, the only thing beautiful that you see, besides other eatable things, is a huge 300 feet high pavan chakkis. Everywhere there is pavan chakki. They came in some fashion in Delhi also. People started with the chimneys, putting a small pavan chakki, did not succeed. The second was solar. Solar was very good. Then electrical cars. Now for last 10 days, I'm being flooded with WhatsApp and stories and articles on email that electrical cars are doing more damage to the environment than petrol. What do I do? I'm really getting confused. I'm a cardiologist. Now they gave a new concept, hydrogen car. And in my lifetime, whether hydrogen car will be there with me or not, I do not know, but I'm happy with my petrol car. Okay. So now they said, those are factors which I showed. My predecessor was very kind. He has read this slide very well. The only important thing is please look into the second part. इसके थोड़ा light बढ़ा सकते हैं क्या आप लोग? मैं भी नहीं पढ़ पा रहा हूँ. ये लोग कैसे पढ़ेंगे? सर मैं भी नहीं पढ़ पा रहा हूँ. आप कुछ करिए मदद. Look into the second aspect. कोई लाइट बंद हो सकती है क्या? थोड़ा सा लाइट कुछ पढ़ ही नहीं आ रही कि ये सब डेलीगेट लोग जो है ना एक दूसरे को देख रहे हैं पढ़ने. चलो थैंक यू. Look at the second part. The exogenous factors or factors that are potentially modifiable. Now, high dose statin therapy. Now, Dr. Mohan is a very, very articulate person. He keeps on studying a lot, and I take a lot of good advice from him. There's some, Dr. Modi doesn't help me out. But what is a high dose statin therapy? What is the optimal? Once I define the optimal, then I can say, well, this is high, this is low. So that's something possibly we can reduce down. Excessive alcohol intake. Now, again, what is excessive? I really do not know. We'll see after 2 hours when they serve at the bar. Huh? Dr. Rajput, can you help me? What is excessive?
It has been defined. Safe limit has been defined.
No, I'm saying excessive. I'm not saying safe. Yes, Doctor Sahab. Doctor Sahab, बैठे हुए हमारे जयपुर गोल्डन के मालिक. सर, वाइफ का मैसेज बाद में पढ़ लेना. ये बताओ एक्सेसिव अल्कोहल क्या है?
I don't take that. I don't.
इसलिए इसीलिए आपसे पूछा है.
It has been defined by WHO.
सर इंडिया के बताओ. WHO
is for all over the world. More than 200 ml.
Including China.
Absolute alcohol per week for males and more than 100 ml absolute alcohol per week for females.
Now you put a rider, sir. Absolute means what?
Absolute to convert to 40% discount. You know 100%. 2.5 times can be this. 2.5 times can be this.
कितना? 500 ml whiskey एक हफ्ते में. That is excessive or normal? And what is non-excessive?
That is
okay. Then now the third column is where I want to draw some attention from you people. Please, drug interaction, notably uses gemfibrozil. It is a very commonly used medicine. When you combine with a statin, a lot of our patients suffering from several diseases. So kindly be very, very cautious. Possibly you can avoid using this. You've got other better products. Antipsychotics. If Dr. Mohan again mentioned something about stress in the common life. And a lot of people, I served in the government for 30 years and I know a lot of middle level government officers are absolutely maybe depressed, maybe they are psychotic and they're on a lot of tranquilizers and antidepressants. And now I'm not saying antipsychotics, but possibly they could be affecting the statins, could be causing a problem. Amiodarone, cardiologists and physicians use amiodarone left, right, and center. It's a very important medicine. So possibly, remember, this could cause a bigger statin intolerance. This is one, we must be very cautious. Verapamil, a calcium channel blocker, which was introduced some 4 years back, and one of the very safe and useful calcium channel blocker, could cause an interference with statin. Be aware and be cautious of that. Cyclosporins, antibiotics. Now, what are those antibiotics? General physicians, while sitting in the chambers, any small fever, any sore throat, they will immediately start and put patient on an antibiotics. So please remember, modifying or changing or avoiding antibiotics along with statins could make a huge better difference. Antifungals, protease inhibitors, and now excessive exercise. Now again, this is a very, very important aspect. We ask our patients, please walk this much distance, come back. Do cycling, do aerobics, some anaerobics, some weights and all that. So everything has to be defined by a physician or therapy. Do not ask patient to jump on a yoga line. What is and how much is yoga? What is yoga is a common misnomer. Possibly people do not know what does yoga mean itself. So you be very cautious. These are factors where we as a cardiologist and physician must put our attention on this aspect. And then the last point is excess grapefruit juice. No, it's not fermented. It is causing only of the grape. Luckily in India, only in Andhra Pradesh, a lot of grape juice is taken, otherwise not being taken. Now, my predecessor already described the three aspects. That is patient counseling, statin-based option, and non-statin option. I want to just draw your attention on the last column. What are the non-statin options to bring down the cholesterol, to bring down the LDL levels, and without having the bad impact, bad side effects of the statins? First is ezetimibe. This medicine was introduced in 94-95, came up in a lot of use, but again was withdrawn in the last 10 years. There is a lot of attention way back. This adds to some 10 to 12% to 15% if combined with statins. So we can reduce the dose of statin by combination of ezetimibe. Resins have been used for last 60, 70 years and very safe and comfortable. Possibly can, if not replace, can substitute or add on with statins. Fibrates have been popular in this country for donkey years. We must try to be more emphatic and more emphasizing on this. PCSK9 inhibitors, the only disadvantage is injectable, but very, very effective. And second thing is very expensive also. For a country like India, possibly government has started giving this in the CGHS now. And maybe that next step, the state governments also start giving this free of cost to the patients. And bempedoic acid is again a very useful chemical compound which can help us in reducing the dose of statins. A good amount of studies are there. Then for this bempedoic acid, there were 4 different studies were there, and they were all short duration. Maximum was only 52 weeks, but it did show a beneficial impact and effect with lesser number of side effects. So my dear friends, all I want to try to say is 2 points: that try to treat a patient in holistic way in totality. Do not focus only on his LDL or total cholesterol. Try to see that a good mind, a good physique, and good dietary control with limited amount of statins would possibly do more wonders than anything else. And the patient is not comfortable. Do not hesitate in switching over, substituting, adding, or making more than one statin give up to the patient. Thank you very much.
Had 2 wonderful talks, and after that, are there some questions we can address them, or how do you want to start?
Sir is giving very good lecture, and regarding about the statin-induced myopathy, and Dr. Singhal is already giving the good lecture, and I think so it's a very good challenge in our world, and a lot of people is I am practicing in the village peoples, and I saw that a lot of people taking medication. What happened is going on, uncompliance of medications, in even statin-induced myopathy. But its counseling is very important, and I really appreciate for Dr. Singhal, and already he's giving the checklist chart. Is very, very good. And I think so, sir is senior and everything is explained regarding about what is going on statin and rosuvastatin and atorvastatin, how much dose is giving. But counseling is my point of view. Counseling is very important, sir. Thank you.
Although we have discussed a lot of side effects of statin, but overall, I think the statins are the safest, one of the safest drugs available in the modern medicine, and we should not fear about small muscle pains and here and then. We should not reduce the dose based on the very trivial symptoms, because many times we doctor ourselves suggest that if patient complains even little amount of pain, and we tell them that it might be due to statin, so we can reduce. So statin causes a lot of benefit, and that have been proven in a lot of trials, and we have more than almost 40 years of experience with statin. All the newer drugs are good, but there is a lot of way to go ahead, and only one trial is available, that too in statin intolerant patients. So we do not have any head-to-head comparison of bempedoic acid with statin. So ultimately, our first choice should be statins.
As far as bempedoic is concerned, I mean, it is known that it does not cause any muscle symptoms. And in fact, at the cellular level, the basic difference is that it doesn't cause. So it can be used as an add-on therapy when you are not able to achieve the LDL goals, and statin intolerance patients where you can't use any kind of statins. Most of us have at least few patients in our practice where these patients are really intolerant and not able to tolerate even the smallest dose of any statin. And I have at least few patients where even they could not tolerate pitavastatin. So statin tolerance is not a myth. It is there. There are patients who have problems, but at the same time, if you counsel them properly, what is called nocebo effect, they read so much literature about that this can cause muscle damage, this can cause pains. So many patients have these symptoms, and they perceive these symptoms. So that considering that has to be taken in consideration. And any more questions in chat box or anything?
I agree with the doctor that statins are probably the most useful cardiac medicine which we have come across in last 3 decades, other than beta blockers and heart failure. So these are the 2 drugs which I give full, marks to these 2 drugs. I have changed my practice in last 8 to 10 years. I don't tell the patient that I'm giving you cholesterol medicine. I clearly tell them this is a medicine to reduce your reduce the chances of your second heart attack. This is the medicine I'm giving you to reduce the chances of a stroke, this and that and this. Yes, it also reduces cholesterol, but that's not the reason I'm giving you the medicine. Straightforward. Believe me, all of you sitting over here, including Dr. Mohan, that chances of muscle complaints have come down by almost 4 to 5 times by the patients. They don't complain once you tell them that this medicine will, in fact, if you see scientifically, this is the only medicine which prevents the second heart attack, at least other than, along with aspirin, you can say in the secondary prevention, but primary prevention, there is nothing else which prevents first MI other than statin. So once they understand the importance of statin, at least vague muscle pain, they will not complain. I'm not talking about myositis, rhabdomyolysis, which I have very rarely seen. I have got one patient in last 20, 25 years practice of real myositis. I don't know how many
I think,
true myositis you people see.
Myositis is not that uncommon. Rhabdomyolysis I've seen 2, and everybody must have seen 1 or 2.
I've never seen.
But myalgia, significant.
Myalgias, that's what I'm saying.
Significant limiting myalgia.
For myalgias, they stop complaining of muscle pains if you tell them the gravity of the drug or the importance of the drug. Myositis is different. That is when the CPK is high or when you have the laboratory things going on.
Just we need to explain the patient that the medicine is causing so much of benefits. So
actually speaking, as a cardiologist, you are giving medicine to reduce the ACS and reduce the progression of atherosclerosis. Why should we worry about LDL and all?
Also, sir, we can do out of the immunology factors. We can check by myositis also, because sometimes
sometimes rheumatoid arthritis and with coronary vascular disease.
I'm not saying statins do not have side effects, but the common side effect for which we stop statin is muscle discomfort here and there. And we ask the patient, many times I have seen the physician asking, koi muscle pain to nahi hai? Why ask the patient muscle pain to nahi hai? If you are too much worried, get a CPK done. I do CPK after 3 months of starting statin as a routine.
Doctors is very, very small doctor. People asking if muscle ye match nahi kar raha. People are giving the mistakes for us. He came with us and he told us, sir, ye medicine match nahi kar raha hai, stop it. We are already
Even I'll blame Cadila people. The both lectures on statin, you have only talked about intolerance. You haven't talked about the benefit of statins at all. There are newer indications of benefits of statin. So kitna bhi oppose kar lo, jeetega to Modi hi.
Sir, one question I want to
comments or questions, sir?
Yes. I want one. There are 2-3 points. India is a very vast country. You are all very fortunate to work in a very hi-fi city, but we work in very small places and we have got our own problems. I was very much impressed by a very good message given by Dr. Mohan regarding the salt. I have seen that people who are taking diuretics and AC inhibitor, they land into hyponatremia. In my mind, in my thoughts, it is very dangerous to ask the patient to restrict salt too much. Too much salt restriction is very dangerous, and we are seeing plenty of cases of hyponatremia with neurological complications and other complications. So my practice is I ask the patient, avoid the salts which are extra and just reduce 5 to 10% salt in their diet, and they do very well. The second question is statins are no doubt, they are very wonderful drugs. The issue regarding bempedoic acid is settled. Bempedoic acid is not free without side effects. We have got a reduction in GFR, and we also get the derangement of the LFTs, though myalgias are not seen. And it is seen that low dose of the statins if we are taking, the effect of the bempedoic acids are more than if the patient was already on the high dose of statins. And whether the bempedoic acids has effect like statins in reducing the cardiovascular mortality, as if we use it as a single drug, we still don't know. So statin continues to the wonder drug, as Sir was telling. I do not think in the present scenario, nicotinic acid has any role to play in the treatment of hyperlipidemia. It is not a good drug. It's called loss of side effects and propensity to cause diabetes. Regarding the liver enzymes in patients who are taking the statins, if the person is having more than 3 times the elevation of liver enzyme, there is no need to stop the medicine, in my view. I like to Dr. Mohan to please clarify it. And you can half the dose, but if it's more than 5 times, we have to stop it. And most of these studies, they say that we need not to repeat the liver enzymes many times. And there is no need to do CPK enzyme at any time, excepting when we find that patient has symptoms of necrotizing myositis, or patient is having a painful myopathy, or patient having very severe pains. And in the beginning, there's no point in doing the enzyme studies to start the statins. And statins are still the wonder drugs. Other drugs, we don't know how much effect they have to reduce the cardiovascular mortality. And Sir, Dr. Mohan, I want to ask you one question. What is the status of the antisense oligonucleotides? Presently, a drug has been approved by the FDA. And what is the present scenario with enoxaparin to silence the messenger RNA? Thank you very much.
So inclisiran is not a antisense oligonucleotide. It is a small interfering RNA. Small interfering RNA molecules can be given once in 6 months to 1 in 12 months. Inclisiran is approved in Europe. It is being used significantly in United Kingdom. It is quite expensive. Inclisiran application was put into DGCI on behalf of one company, I'm forgetting the name, but 2 weeks back, DCGI turned down the application. They did not approve inclisiran. So these people, by law, by convention, they can only reapply after 6 months. So up to 6 months, we are not likely to get inclisiran.
Dr. Mohan, this is being evaluated in India, and we are part of this trial, inclisiran Orion Prevent trial. So this is about inclisiran.
That is different, I know, sir. But is it available in India?
Not at the moment.
So let us try to understand how drugs are labeled. Those which have MAB at the end are monoclonal antibodies. Those which have seran at the end are small interfering RNAs, and those which have sen, SE and sen, they are the antisense oligonucleotide like pelcarsen. So just to say, so we have 3 varieties, but the names are different. The last words are MAB for monoclonal antibodies, seran for small interfering RNAs, and sen for antisense oligonucleotides. So that's clear. We know that inclisiran data is going on, but an expedited application was put forward to DGCI, and DGCI just actually turned it down 2 weeks back. So we know that that is where we stand. It is a very expensive drug, even in United Kingdom. So it has a certain limited indications, largely for a certain group of individuals associated with familial hypercholesterolemia and some very high-risk individuals. Having said that, I think we did have a good discussion on dyslipidemia and therapy, but we need to actually point out a few things. All speakers have said that LDL lowering is important. Now, because we have data after data, we have layer after layer to say that lower is better. One of those Indian lady who presented in AHA, the Fourier-Ole data showed that those who had 10 milligram LDL vis-a-vis those who had 100 milligram LDL, the risk reduction was relative risk of 25%, with no adverse side effects to those who had a median LDL of 10 milligram. So we are getting to the point that lower is better. We have a strong lobby against LDL, even amongst cardiologists from India. And if you're a part of the WhatsApp group, especially from All India Institute, there is a lot of people who are strongly against statins.
Why is that so? Any idea?
No, because people always have lateral thinking. The world is full of people with lateral thinking, actually, and you can't do anything to that. If an intelligent person has eccentric thinking, that is the worst thing, because he or she is able to influence a lot of people, but the patients are harmed in the process. So at the moment, we have to accept that fenofibrates and niacin are out. So the good part is fenofibrates have no role in management of dyslipidemia. We got this clear message from prominent study which was presented in AHA in November. 9,800 patients of diabetes, high-risk diabetic, fenofibrate versus placebo, 5 years trial, multicentric, multinational, very well conducted, and absolutely no benefit, although there was a TG reduction of 30% and HDL improvement of 10%. One thing we have learned, fenofibrates are out of the sphere. This orbit of fenofibrate out. We also have the niacin out of this orbit. So we are left with 4 drugs: statins, ezetimibe, bempedoic acid, and saroglitazar. Why saroglitazar? We don't have any outcome data, but it does lower LDL by 10-12% and non-HDL by about 17-18%. We have to accept it when the facts are there. So there are 4 drugs, and so the fifth being the Cumabs, actually, evolocumab and alirocumab. But of course, again, the oral PCSK9 inhibitors, which a large amount of data was presented in this ACC, are the future. There is no doubt in my mind. They are the future. And If things like inclisiran can be cheaper, I don't mind having a vaccine once a year and keep my LDL to 30, 40 rather than taking a drug every day. But somehow the inclisiran has to come down to that 500, 600 rupees or 1,000 rupees I can pay for every 6 months. That is not going to happen that easily. So this is the real world. Those who have actually spent so much money on Orion group of studies will probably will not bring it cheaper. For us, these are the combinations available. At the moment, a lot of us, because of this statin intolerance business, have moved to a not the highest possible dose, but a modest dose, 40 of atorva, 20 of rosuvastatin with ezetimibe and or bempedoic acid. This is how most of us are at the moment trying to get along and try to get those targets which the ESC settled in 2019 and then were endorsed into 2021 by ACCHA. We are largely in the same range, except that the LDL continues to be below 70 by the ACCHA and below 55 by the ESC, and Lipid Association of India says below 50 milligram for very high risk individuals or those with atherosclerotic cardiovascular disease. Of course, our primary prevention, the guidelines are different, and we all, of course, are aware of that. Our issues about residual risk, actually, which Rakesh was given and which are an extremely important topic, unfortunately got sidelined. Dr. Paul Ridker, actually, this ACC 2 months back, did a beautiful analysis of residual risk, which lies in inflammation. He looked at meta-analysis of 2 studies, strength and reduce it. Now, there are 25,000 patients. There is a linear relationship between inflammation as shown by high-sensitive CRP and atherosclerotic cardiovascular events. But this risk is not linear with LDL. In first quarter and fourth quarter, you divided the whole thing in 4 quartiles. If you move from quartile 1 to 4, inflammation, consistent increase in stroke, consistent increase in myocardial consistent increase in heart failure, consistent increase in revascularization need, everything is consistent. The moment you actually base on LDL, residual LDL, because now you have data of those who have been treated and those who are not, or who are on let's say active drug and placebo, which includes actually statin in most patients. You are clearly seeing that at a certain level, LDL loses efficacy as a predictive agent, but CRP continues to have predictive power, which actually means next target is going to be inflammation. Whether colchicine, which has been tried in Lodoco 1, Lodoco 2, Colcott, will become an agent for us to be used. Anything else new will come. Remember, bempedoic acid lowers CRP, statins lower CRP. Yeah, method. But the point is, the next big thing is going to be how to reduce inflammation. Besides of these drugs, whether colchicine should come forward. Unfortunately, data with colchicine is good, but data is inconsistent. Which component of major adverse cardiac event being affected in all 3 studies is very different. Now, if the same drug is working, it should have same consistent effect. MI is not affected, stroke is affected. Stroke and MI is not affected, unstable angina is affected. None of this is affected, all-cause mortality reduced. Problem with all this thing is that, but we still believe that inflammation would be a target in future because atherosclerosis is a chronic inflammatory disease. Macrophages come up because there is inflammation. Actually, monocytes move in the subintimal space simply because they initiate the inflammation. So we would have to do. So the point which I was trying to make is that Rakesh had a wonderful task to talk about residual this thing and the way we can go forward. Remember, canakinumab also was shown to be effective in this CANTOS trial, actually. The only thing is Novartis did not pursue it as an anti-atherosclerotic drug because cost is high and the benefits were small. But nevertheless, and there were other issues, I think, a little bit other issues of some hepatic side effects, I think, with canakinumab. But nevertheless, inflammation remains a strong target for the next 5, 10 years, 15 years, as far as prevention is concerned.
I think, sir, the sequence of events is we discuss and we talk what we have proof for. First of all, the whole story of LDL, lipid theory began with high LDL being associated with disease. The next target was bring it down. Can we reduce the events? Answer before statin was plus minus. And then came statins, and then it was a clear-cut answer. Then came the issue, is it working through LDL or is it working through some other mechanism? And then all of us talked for decades about those pleiotropic effects. Now we are coming back to the same again. Do we need something more than those so-called pleiotropic effects and to target that anti-inflammatory thing? As far as the options also decide our choice of treatment. If you double the dose of statin, do you get the double reduction in LDL? Answer is clear, no. It's only 6%. So all the while for last 10 years, we were looking for that if LDL is not at the target, and if I want to achieve that, should I double the dose of statin? That's how bempedoic, ezetimibe, PCSK9, and then inclisiran and other therapies are coming up. So eventually, maybe we can talk about something now. Maybe 5 years later, we will be talking something different as the evidence gathers.
But you know, the reason I talked about colchicine and inflammation is there is this person from Stanford, Kevin Vaidya, who's an Indian with the born in United States with Indian origin. This man did a wonderful study. He compared 3 groups: colchicine alone, colchicine plus statin, and statin alone. Looked at CT coronary angiogram of people and looked at the vulnerable plaques, especially the so-called what we call it as low attenuation plaques, which is a euphemism for yellow plaque or for lipid core or necrotic core. And this definitely got reduced by colchicine, more by statin, and much more by the combination. So we do believe the inflammation has a residual role. It may not be as powerful as LDL lowering has got. But anyhow, things remain exciting actually in this area. And we look forward to this space with great expectation. The only problem with us is many amongst us still are not convinced. Those are endocrinologists and nephrologists. Remember, in moderate CKD, is a high risk individual, and severe CKD is a very high risk. So the targets are less than 70 in high risk and less than 55 in this. But the nephrologists don't prescribe high dose. And endocrine or diabetologists, half of them prescribe, half are happy with 10 milligram, despite actually the grading and other things. There lies our major emphasis.
So one more point in Indian scenario is that many of our patients to whom we give statins for secondary prevention, they might have very low baseline LDL. So in those patients, the target should be 50% reduction rather than 50 milligram per deciliter.
Absolutely. That is exactly what I was talking about. This lady, I think her name is Prakriti. She actually showed from Fourier-Ole that those who had 10 milligram LDL, they had further 25% reduction compared to 100 milligram. So even 10 milligram is better than 20, 20 is better than 30. There is no doubt about that. The only issues would be de-escalation still in the minds of many cardiologist physicians. I have now the LDL of 30. Should I decrease the dose? The guidelines are very clear. There is no need to de-escalate. But their physicians actually keep de-escalating. And the people will give lecture, when will I de-escalate statin? They are doing biggest disservice to people. I just want to tell you personally, and don't think that this is the right way of doing, but I will tell you my conviction. I take 20 milligram rosuvastatin, 10 milligram ezetimibe, 180 milligram bempedoic acid, and I take Repatha, and I take saroglitazar. I'm just trying to tell you how much I'm convinced about LDL theory. Maybe irrational, maybe something. But what I'm saying, I'm so much convinced about this whole business.
How much am I convinced with the statin? I'm taking 80 milligram atorvastatin for last 24 years.
And I'm taking for 31 years actually.
Uninterrupted, not a single day missed, never had any. I mean, this is not secondary prevention, this is primary prevention.
But dear friends, let's not follow the anecdotes.
Yeah. but the only thing is muscle cramps do occur. You have to agree. Whatever is the number, muscle cramps do occur.
With all of us sitting here, I just want to pose a question. What is your experience of LDL reduction in our population with statins? Is it more than what is written in literature? Is it less? Or it is much more?
I am taking 40 milligram
either
of
equal or
atorvastatin.
more.
I am
It is
taking 40. I am taking
very responsive. We are doing a trial, and all of us, the inclusion criteria is non-CAD, PAD stroke, rosuvastatin 20, atorvastatin 40, LDL more than 70. We have screened 800 plus lipid profile, 12 patients.
I take 40 milligram of atorvastatin. There are no side effects, and I am told that there is no need to get your lipid profile done now. Continue with it.
How much is your LDL, sir?
My LDL is 53.
That's pretty good. But I do agree that there is a strong feeling that Indians are hyper responders. The same kind of data was published in IRIS study by Prakash Didwania some 15 years back. And the FDA has a warning that people of South Asian origin should start with 5 milligram of rosuvastatin. So there are data actually also, but we also are aware that a good number of Indians are hypo responders. Good number, and I am myself a hypo responder. Even with 80 milligram atorvastatin, my LDL would not budge at all. Forget about 5 milligram.
It means that hyper responders will be hypersensitive to side effects.
We don't know. I don't know. But the fact is that there are people who just don't respond. And I know of this fact. I know of my younger son whom statins just don't work actually. I mean, they will reduce 5-10%. It is a pitiful situation. So I agree. In general, Indian population is hyper responder. But within the population, we do have hypo responders. Yeah, genomics, absolutely. No, there is a KIF gene, KIF7 gene, which has been shown actually its loss of function, gain of function, decides whether you respond to statins and how much you respond to statins.
Thank you very much. We had wonderful discussion, and that goes to highlight how much we know about statins and how much more we need to know about lipids. Thank you very much.
Thank you, sirs. And now we are almost more than halfway, and we are left with 3 more talks. But before that, as I said initially, we would be stopping for a bio break and a tea break of 15 minutes, and we will be gathering after 15 minutes for bio break. Yeah, both the things. Thank you so much. We will be meeting after 15 minutes of high tea break.
Hello.
Very good. Happy to see. तेरी कुर्बाई हो गई. And then finally, this man joined the army. The girl gets married, and the girl gets married to an army man, as usual in Himachal. Then she tells this boy who now has grown up to take care of this, and he takes bullet for her, bullet for him. That is beautiful story.
Yeah. So, welcome everyone after the tea break. And now we shall be moving on to the third session. And in this third session, we would be talking about another important aspect that would be antiplatelets and anticoagulants. And as a mentor for this session, we had the blessings of Dr. Subhash Chandra sir. He is a well-known figure across the country, an eminent cardiologist, and he mentored the session, and that actually was the reason for the selection of the topic. So, at this point of time, without wasting any other further time, I'd like to invite Dr. Chandra sir over the dais and to proceed further with the session. Please.
Thank you. So, dear friends, welcome again. Good news is that in this third session, the topic on angina, multifaceted angina, give us time and give us opportunity to discuss better aspects on dual antiplatelet therapy. We are fortunate to have a very eminent speaker in Dr. Sunil Modi, who is with us. This topic is very relevant for our day-to-day practice being in the interventional arena. There's always an enigma that how long should DAPT be given and when should we abbreviate its usage if we are dealing with high bleeding risk population. If your post-PCI patient happens to have atrial fibrillation, how should we utilize the anticoagulants along with the antiplatelet drugs? So those are very important aspects, and I'm sure Dr. Modi will do justice. Though the topic is very exhaustive, but the very fact that this is an open topic and there's no consensus as to how should we shorten or prolong therapy in these patients. So let us hear Dr. Modi here. And even you would appreciate that between the European and American guidelines, there's a difference. European guidelines say that 6 months is enough, whereas Americans strictly say that it should at least be 1 year of DAPT. So let us hear him. Sir, please welcome.
Yes, sir. So before that,
See, knowing that the slide view is not very optimum, I'll just focus and concentrate on few things, and do not want to, feel you bore in the sense of.
You invite Dr. Pachar and Dr. Mubin or the chairpersons.
Where are they?
They are here. Dr. Mubin.
Oh, sir.
Dr. Mubin
Please.
is a cardiac surgeon. Please join us as chairperson. And Dr. Pachar can also come here. Please come. From SMS Jaipur. Please come.
Thank you very much. And sir, may I have your permission of starting? Sure. It's a very brief subject in the sense that we are only talking about dual antiplatelet drugs after PCI. There is no atrial fibrillation topic included in this. So balancing between ischemic and bleeding risks. All of you are aware of these problems that whenever, see, acute coronary syndrome or STEMI, non-STEMI, acute unstable angina, the pathogenesis is now very clear in last 2 decades, not before that, is that there is a plaque rupture that occurs very suddenly. The plaque develops over years, but then the rupture of the plaque occurs very suddenly, and that's how the acute coronary syndrome develops. And that fits into the story of that somebody who is absolutely healthy, running around, no symptom, normal treadmill, suddenly gets a heart attack because his plaque is not occluding the lumen to produce symptoms, but then once it ruptures, it attracts thrombus and there is sudden blockage of the artery, and that leads to the complication. So pathogenesis of ACS is rupture of the atherosclerotic plaque, and that is the cause of the okay. Now, if you think when we do PCI or angioplasty, we do exactly the same thing which nature does in producing acute MI. Spontaneous plaque rupture, acute MI. We rupture the plaque with balloon and we produce balloon-induced plaque rupture. So actually the mechanism of PCI and the ACS is exactly same. So why we are emphasizing on this is that whenever there is a plaque rupture, whenever the blood comes in contact with the plaque, and particularly the lipid component of the plaque, now lipid doesn't like platelets don't like lipids. So there is an immediate hyperactivity of the platelets. As soon as the plaque ruptures, the platelets become activated or very aggressive. Platelet was the chapter in our physiology days which we conveniently ignored. We focused more on the RBC, WBC, and as soon as the platelet chapter came, we ignored it without knowing that if you become cardiologist, platelets are going to be the most important organelles. So there is these are the electron micrograph of ACS where there is actually like pseudopodia thrown by the platelets, which are not there otherwise. Otherwise, platelets are ellipsoid, regular oval-shaped organelles. But as soon as the plaque ruptures, the platelets through pseudopodia, and then they start entangling with each other as well as they adhere to the vessel wall. So this all happens within minutes of plaque rupture, thereby producing platelet aggregation, platelet thrombus. So activated platelets are central to the thrombus formation in ACS. So is the case with PCI, with the angioplasty, adhesion, activation, aggregation. So these activated or very aggressive platelets need to be suppressed or need to be inhibited also very aggressively, which will mean that we have to act on several sites. One site inhibition may not be sufficient. So do we have any other method of changing it? Okay. So we know that aspirin will inhibit thromboxane site. There are other sites, ADP, your P2Y12 receptor. So in a activated platelet or superactivated platelet scenario like ACS or angioplasty, we need more than aspirin, more than one antiplatelet. And that is how the concept of dual antiplatelet, both for the spontaneous ACS as well as for PCI, had developed over a period of time. Okay. So after PCI, patients will remain exposed to the ischemic events, thrombus, particularly if you have not expanded the stent adequately. If the stent has still lying in the lumen somewhere, and this is not uncommon, without use of those IBUS and OCTs and so many things, when you expand just on the basis of visual angiogram, there is a very good chance that you may not be able to expand the stent 100%, and there may be suboptimal expansion, which will attract platelets and thrombus more. So this antiplatelet business remain more relevant if there is a suboptimal angioplasty. Okay, so dual antiplatelet therapy is the cornerstone in the management of patients with acute coronary syndrome, as well as in the patients who undergo PCI. Use of DAPT in reducing the risk of thrombotic events by acting on at least two key pathways of platelet activation has been recommended and has been followed. Current guidelines recommend 12 months of DAPT with aspirin and one of the oral P2Y12 receptor inhibitor, preferably ticagrelor or prasugrel or clopidogrel in that order, because we have learned over years that ticagrelor works better than clopidogrel, particularly keeping in mind that clopidogrel patient may be less sensitive or less responsive to clopidogrel, or sometimes over responsive to clopidogrel. So looking at that, ticagrelor has been accepted as a standard second antiplatelet drug along with aspirin in patients of PCI. After elective PCI, DAPT with aspirin and clopidogrel has also been recommended for 6 months. Though again, stable angina PCI, acute coronary syndrome PCI, STEMI PCI, there will be difference. The platelet activation or hyperaggression will be much more in patients who present with acute coronary syndrome and the PCI is done. DAPT duration is tailored to the individual risk. How long should you give 2 antiplatelet? When should you come to 1 antiplatelet? Depends on the individual risk and your assessment. If patients are deemed at high bleeding risk, then the DAPT duration can be shortened by up to 3 months or even up to 1 month in some of the studies, and in cases of both ACS as well as elective PCI. If there is a low bleeding risk and high ischemic risk, then DAPT can be prolonged even beyond 12 months. So 12 months is a standard recommendation. It can be cut down to 6 months, 3 months. It can be prolonged beyond 12 months, particularly if there is a continuing risk of ischemic events. Now, there are many alternative approaches have been discussed, and there are many trials, which I'm just going to show you quickly, which have changed the idea of duration of the DAPT, particularly in those patients who need to be changed, high bleeding risk or high ischemic events. So these strategies, which are generally tailored according to the patient's risk profile, and genetics and platelet function, have been proposed to individualize the treatment to mitigate the ischemic and the bleeding risk. So you understand that any antiplatelet which is more potent will also be more potent to give bleeding. Higher is the potency of antiplatelet drug, more will be the chances of bleeding. So one has to balance somewhere that we need this much of antiplatelet potency, and then we don't want too much of bleeding. So it's a balance of these two things. Ischemic risk in a patient is judged by the patient scenario. If patient is presenting as ACS, prior MI, peripheral artery disease, diabetic patients, heart failure, prior stent thrombosis, CKD, multivessel disease, multiple stents, small vessels, stent length more than 60 millimeter altogether, or treatment of left main, proximal LED. There are many situations like these which require more potent antiplatelet and for longer duration of time. As far as bleeding risk is concerned, it is also can be judged by the fact that patient has history of major bleeding, prior or recent major bleeding, prior stroke, frail patient, advanced age, ongoing malignancy, low BMI, anemia, thrombocytopenia, CKD, ASRD, chronic use of non-steroidal anti-inflammatory drugs, oral anticoagulation, liver disease, excessive alcohol consumption. So these are the patients whom that these patients are more likely to bleed. So I think this is a very important slide for a clinician to decide what does he want, whether he wants to deal with he's dealing with a high risk bleeding case or low risk bleeding case or high ischemic event case. And that is where now there are many scores. I'm not going into details of those scoring systems because I don't do it. I don't know how many people do it here, but there are scores given, Paris score with all these points. Then there is a DAPT score giving the points. If somebody is interested, you can find it in the literature. These scores are basically to tell you how much is the risk of bleeding, how much is the risk of ischemic event. But I think before that, the two slides which I showed you probably is the best way to judge. This will be the best way to judge in my practice, that these are the cases who will have high ischemic events. Those are the cases who will have high bleeding risk. So judging these, it's not very difficult to find both ischemic as well as the bleeding risk. So going through those scores, and then risk assessment of guiding antiplatelet therapy, bleeding risk, antiplatelet responsiveness, ischemic risk. Again, we are repeating most of the things. So overall, you have to assess the risk of how bad is the risk of further ischemic event or the bleeding risk. Patient-related factors is stable CAD or ACS, anatomy-related, short lesions, single vessel disease, stent-related, second generation DES has less incidence of the ischemic events or the stent thrombosis. So less than 12 months DAPT in those patients or lesions which are more suited for less ischemic events, and one can even continue 12 months or more DAPT in patients who have diabetes mellitus, renal dysfunction. If somebody has an incidence of stent thrombosis in the past, long lesions, small vessels, so on and so forth. So a personalized approach in an individual patient to decide the duration of dual antiplatelet drugs. Now, just to give you three studies which have in last few years, which are changing the concept of duration of DAPTs. One of study is very important, Twilight study. What they did in this study is that after 3 months of dual antiplatelet, aspirin and ticagrelor, aspirin was stopped on one arm, one side, and the aspirin was continued on the other side. So 3 months, both antiplatelet, after 3 months, only ticagrelor, or both antiplatelets. And the follow-up showed that there was a significantly increased incidence of bleeding in that group, which received both ticagrelor and aspirin, for 7.1% as against 4% of incidence of bleeding, where we used only ticagrelor. And there was no significant difference in the incidence of ischemic events like MI, stroke, or stent thrombosis and death from the ischemic event, telling us that probably those patients who do not have very high ischemic event chances, one can stop aspirin after 3 months, particularly if there is a high bleeding risk. See, you will tend to stop aspirin only in those patients where there is a higher risk of bleeding. The stop DAPT 2 ACS trial showed that 1 month dual antiplatelet versus 12-month dual antiplatelet, and after 1 month, rest of the 11 months is only clopidogrel. On one side, it was dual antiplatelet for 1 month, 11 months with clopidogrel alone, and the control group was all 12 months dual antiplatelet. Now, obviously, bleeding was less, but then ischemic event rate was significantly high in those patients where aspirin was stopped after 1 month. So clopidogrel alone doesn't seem to be equal or better than dual antiplatelet in this study, whereas Twilight study, we saw that if you switch on to only ticagrelor after 3 months, it can work as good as combination. So there is a difference in these two studies. The stop DAPT study tells us that one should not be using clopidogrel alone, like in this study after 1 month. Another study, host exam study, the bleeding is mostly from gastrointestinal tracts in these patients. And it is very well known right from the beginning of clopidogrel use that as far as GI is concerned, aspirin is worse than clopidogrel. If you compare aspirin and clopidogrel, then aspirin, the GI side effects are more with aspirin as compared to GI side effect with clopidogrel. So this trial tells the same thing, that after, if you don't have any event for 6 to 18 months, then you switch on to only aspirin or only clopidogrel. So clopidogrel patients perform better as far as bleeding risk is concerned. So if you have to choose one antiplatelet, choose clopidogrel rather than aspirin. This is what is the essence of this trial. Pegasus TIMI 54 trial, ticagrelor in patient with stable coronary artery disease and diabetes, again showed similar things, that you reduce ticagrelor 6 to 60 milligram twice daily, along with aspirin, still has higher incidence of bleeding as against the only ticagrelor has less incidence of bleeding as compared to ticagrelor plus aspirin. And major bleeding is also different. So ticagrelor significantly reduced the risk of CV death, MI, and stroke, and increased the risk of major bleeding. Now, this is just very recent, 3 days ago in EuroPCR, interesting study, which will have its own implications very soon. The Optica study. In this study, the main feature was that this angioplasty stentings were done with the most meticulous use of OCT, IVAS, whatever was required to make sure that the stent expansion was excellent. This was only those patients were studied where the stenting was optimum expansion of the stent. And what they did, that they used single antiplatelet right from the day one after PCI. They didn't use dual antiplatelet at all. So single antiplatelet therapy directly after PCI in non-STEMI ACS. This is not STEMI patient, only non-STEMI patients. And they found that there was no significant increase in MI or in stent thrombosis using ticagrelor or prasugrel. Both have been used in this study without aspirin right after optimal PCI. That is a focus in this study, that you must do optimal PCI. Up to 6 months, there was no increase in there was no stent thrombosis, no increase in the ischemic event. But authors speculate that stent thrombosis is related more to the suboptimal stent expansion rather than to device thrombogenicity. So we are worrying too much about dual antiplatelet because probably we don't do the optimal expansion of the stent. That is the point in this study. I think we'll have to wait and watch and probably do larger studies to prove this point. And but I think it makes sense. So use of dual antiplatelet for patients after PCI, stable heart disease, unstable angina, the ACS, stable ischemic heart disease, drug-eluting stent, more than 6 months of aspirin plus clopidogrel class 1 indication. Discontinue aspirin after 1 or 3 months depending on the risk of bleeding, and continue P2Y12 receptor antagonist as monotherapy is class 2A indication. If high risk of bleeding or overbleeding on DAPT, then discontinue P2Y12 receptor after 3 months and only continue with aspirin. Maybe a reasonable idea, but that is 2B. If no high risk of bleeding or significant overbleeding, then dual antiplatelet can continue even beyond 6 months in stable ischemic heart disease stenting, and dual antiplatelet drugs may be a reasonable idea to continue even longer than 1 year, depending on the baseline risk like diabetics, like peripheral artery disease or multi-site atherosclerotic disease. You can even, if there is no bleeding risk going on or bleeding risk, then DAPT can continue even longer. For a BMS, of course, we are very clear that nobody uses BMS anymore, almost like gone. But then more than 1 month of dual antiplatelet, and after 1 month, you can switch on to single antiplatelet therapy. And depending on if you're suspecting GI bleed and all, then keep clopidogrel only and avoid aspirin. For acute coronary syndrome patients, more than 12 months of aspirin plus clopidogrel or prasugrel or ticagrelor is class 1 indication. Aspirin plus one of these 3 drugs should continue for 12 months unless there is a reason to modify this regime. So discontinue aspirin after 1 or 3 months with continued P2Y12 monotherapy, class 2A indication, if there is a reason to stop aspirin in your case. If high risk of bleeding or overbleeding on DAPT, then discontinue P2Y12 receptor antagonist and continue with aspirin only 2B indication. If there is no risk of high bleeding, then try to continue dual antiplatelet in patients of ACS angioplasty for more than 1 year or even longer, depending on the baseline risk of the patient. So to summarize, PCI is equivalent to spontaneous ACS, which invariably leads to platelet hyperreactivity, therefore requires to be treated by more potent antiplatelet drugs acting at different targets of platelet inhibition. Standard practice is to use combination of 2 antiplatelet drugs as long as we think the chances of platelet aggregation is high, followed by single drug. So if you suspect that I have not expanded the stent very nicely, or if for whatever reason the stent expansion has not been there, then you will like to continue dual antiplatelet longer. So if the chances of platelet aggregation is not high, then you can switch on to single drug. Selection of antiplatelet drugs and the duration of dual antiplatelet treatment will depend on the results of stenting procedure, optimum or suboptimal, risk of bleeding, and anticipated chances of ischemic events or stent thrombosis. Finally, use of your own clinical acumen is of paramount importance in deciding the type and the duration of dual antiplatelet therapy for your particular patient. Thank you very much.
So I think you've given a very crisp message that in today's times, the therapy has to be tailor-made for your individualized patient, keeping in mind the risk of ischemia versus the risk of bleeding. We are worried perpetually about the stent thrombosis, whereas the bottom line is that, as Dr. Modi pointed out in the last slide, that if you have deployed your stent properly, where you might take help of some imaging modality or very robust protocol in deploying a stent, the chances of patient coming back with stent thrombosis is actually minuscule. The second aspect is use of DAPTs, and he alluded to various trials, both on abbreviated and prolonged DAPTs. I would ask you, sir, that there has been some data on the NOACs being used in these patients besides the DAPT. If we look at Pegasus, as you told, the extended DAPT can do wonders in terms of preventing ischemic events. And Dr. Greg Stone has also shown that it's not only the stent site which leads to stent thrombosis, there are lesions on other areas of coronary tree which could be responsible for future events. So at least for that purpose, you might require an extended DAPT. And we often do it in high-risk population. We do de-escalate from using ticagrelor for more than a year or so. Maybe you can come down to clopidogrel. So both de-escalation and continuing with same therapy, there has been a new process these days that one can take help of genomics or the platelet responsiveness if you really want to extend the duration. So what I wanted to ask you is about the Pegasus data versus the COMPASS data, which says that if you continue with aspirin with 2.5 BD of rivaroxaban in patients of chronic stable angina in the long run. So what's your take on that? How would you interpret those two trials, and what should be the message out of these two?
I believe we were talking of only post-PCI patients,
Yeah.
So
even chronic stable angina, post-PCI patients.
If you include chronic stable angina also in this group, then COMPASS trial stands true. Yeah. So otherwise, for post-PCI patients only, you can't extrapolate COMPASS data.
So that's the only trial which says that aspirin is the way to go. But majority of trials say that it is P2Y inhibitors, which should be utilized if you're using a monotherapy or single antiplatelet drug.
Generally speaking, if patient is very high risk, baseline characteristics are very high risk. You're talking of diabetes, multi-site atherosclerosis, particularly peripheral artery disease along with CAD. So there are high risk baseline characteristics. That is the group where besides dual antiplatelet, rivaroxaban can be added in the beginning, and whenever the role of dual antiplatelet is away, then single antiplatelet plus rivaroxaban. Okay. See, that has been accepted. Okay. Like if you remember, Karishma trial showed that even beyond 1 year, 2 years, 3 years, dual antiplatelet is better than single antiplatelet in high risk patients. True. Diabetics, multiple MIs or repeated ACS.
Okay.
Strokes.
And your role on the genomics, if I could ask you that, how?
See, since the introduction of ticagrelor, we are out of that headache of genomics and all, because ticagrelor doesn't require genomics. Clopidogrel used to require still from neurologist sides. Clopidogrel uses far more than the ticagrelor. So they still use genomics in those patients who keep on coming to them with repeated strokes in spite of full antiplatelet and anticoagulants. So we have patients on our records where the clopidogrel sensitivity was effectiveness was very low, and the clopidogrel was increased to 150 milligram instead of 75 milligram, and it worked.
Okay.
But because as cardiology, we started using ticagrelor almost in every patient, at least in PCI patients. So we hardly use genomics because we are not using clopidogrel.
So would you recommend choosing ticagrelor even in a stable, chronic stable angina or elective and planned PCI patients?
If there is no high risk of bleeding, I use ticagrelor.
But on what basis, on what data? Because ticagrelor is largely meant for post-ACS PCIs. So in a stable angina, how would you?
Stable angina PCI, not stable angina without
but
PCI.
where is the data on ticagrelor in stable angina PCI?
Stable angina PCI, you are making it unstable by ballooning. As I showed you in the beginning, you are producing ACS. Every patient of stable angina, you are turning stable into unstable.
Sir, Dr. Mohan, your verdict.
I think I will go with the guidelines. In stable ischemic heart disease, depth for me is aspirin plus clopidogrel.
Right.
Yeah, obviously we are talking about because I don't want, the problem is I am very much inclined to agree with Dr. Modi, but we worship the God of evidence. We have to create evidence. Somebody has to show us the evidence that in stable ischemic heart disease, you do PCI, ticagrelor is better than clopidogrel. Unless you do that, we would not be right to do it. Intuitively, it looks right. Do I do it? Sometimes in a high-risk patient, I do it. I'm putting in a stable.
And you may do it for 15 days or a month.
Yeah,
but still you would want to calm down.
In a patient with stable ischemic heart disease, let's say I'm doing a triple vessel angioplasty.
Right.
Or I'm doing a left main, actually. I know this is a stable patient. I am inclined to agree with what Dr. Modi is saying.
Right. And we do it, yeah.
But in general, let's say is a single vessel patient with a mid-LED lesion, an OM lesion, and I do it. I am reasonably happy with aspirin clopidogrel unless I create more data. But having said that, neither of my approaches have any evidence.
I agree with, like the example which he is saying, mid-LED, stable, single vessel, you can give aspirin. Many times I give aspirin ticagrelor for 1 month, de-escalate to clopidogrel.
That's what we do.
So
see, this is all.
De-escalation actually has now very strong data from topical study, Tello's AMI, and Ascent study.
Exactly.
We have 4 studies which have shown that de-escalation after 1 month produces nearly 50% less bleeding and similar ischemic events.
Exactly.
So now more and more of us.
But we should base it on what basis? Should we conduct platelet responsiveness
the point is,
or genomics?
All these, no, they did not actually look at anything. They went by a simple, actually, Bob Harrington's famous diagram. Ischemic events occur within the first 1 month. Bleeding events continue to occur throughout the course of dual antiplatelet therapy. So based upon that fact, stop aggressive depth at 1 month, come down to less aggressive depth and go on.
Absolutely. This is
2017 was the first year topic study was presented in EuroPCR. After that, we had tropical, we had Ascent, and we had a Tello's AMI last ACC. All saying the same thing, de-escalate.
So
I think it reduces bleeding. I have started practicing.
We were supposed to have a left main study. How long do you want to do that?
There also, actually, I do believe the same thing, that 1 month is all right, and then I'll de-escalate. If something has to happen because of the... No, again, the thing is, every single point cannot be answered. My point is that suppose this was an hostile left main, I did it. It is not a bifurcation. I would de-escalate. You ask me, I did a culotte, I did a mini crush, and will I stop will I de-escalate? I would not. So there are individual cases within
individual
cases
approach,
within cases. They are there.
Left main case. If there is no evidence of bleeding, I would continue dual antiplatelet for at least 1 year.
Right.
Straight.
So there's a very large trial recently published in American
It's an
Heart
individual
Association. It's a 13
If there
years
is a risk of bleeding,
real world
chances
data,
of bleeding, then I will be.
and which by consensus says that 6 months is the optimal time that DAPT should be continued in order to have a trade-off between the ischemic and the bleeding risk. Anything beyond that would invite more bleeding risk. Anything less than that will invite more ischemic risk. So there's a
I would largely agree with that kind of data. But you know what we have not discussed, some very important studies which actually can change our thinking a little bit. One of that is Science 30, another is Science 90.
Yeah, so 1 month and 3 months.
Then TICO and TICO STEMI.
Right.
These and also the Ultimaster 90.
Yes.
We should not forget that.
Yes.
It is again telling us that shortening depth, if you do a good job, is a good idea.
Absolutely. Good job
Exactly.
with the third generation stent.
Yeah, it's a good idea.
So somebody was pointing out about the quality of a stent. Biodegradable polymer, without polymer free. Yeah.
Actually, with the prasugrel and ticagrelor, we are using aspirin only because of our historical fear, because we used to use aspirin with clopidogrel because both were not predictable. Right. So with the prasugrel and ticagrelor, actually we don't require aspirin.
So Dr. Modi pointed out that
I have a very strong feeling.
In many of my patients in which I have done a left main PCI, I don't give aspirin, only ticagrelor right.
Yeah, that could be the way to go. Yeah.
I have a strong feeling that use of aspirin will be avoided and use of ticagrelor alone.
Either
after 3 months.
If I think patient is suitable, I use prasugrel, otherwise ticagrelor.
Doctor, you were making some comment, please.
There are 2-3 Korean trials are there in which they used just a single loading of aspirin and prasugrel, and then in later part they did not use aspirin at all, and prasugrel was the only.
So aspirin is gradually going out of favor. I mean, across the board.
Sir, there are trials only with prasugrel without aspirin.
Yeah. So just single tablet on the day of PCI of aspirin, and then prasugrel was continued.
Doctor, I mean, this is practically what happens if there is no bleeding and you don't have high risk factors for bleeding.
But aspirin is actually not required.
Then nobody wants to take a chance, and
80% of platelets are inhibited
give one instead of 2, at least for 3 months.
But I know there are aspirin evangelists in this gathering. You want to drop aspirin altogether. My submission to you is that aspirin is the only drug having been shown to reduce mortality in ACS. You have not an iota of data that prasugrel or clopidogrel or ticagrelor reduce mortality. I am talking of all-cause mortality. We are aware of the fact that Plato did show reduction in cardiovascular mortality. If that was so good, why in ISAR REACT it was inferior to prasugrel? So that, and in Themis it did not reduce mortality. In Pegasus it did not reduce mortality. So I am getting convinced that is a fluke data in Plato. It largely came from 2 countries, India and Poland. We can judge ourselves from that.
How about in Compass, sir? Compass shows that all-cause mortality is reduced, but myocardial infarction-related mortality is not reduced, where aspirin has been used.
Yes.
So that's a paradox.
So the aspirin data is much more bigger.
See, what Dr. Mohan is saying is correct, that all-cause mortality was reduced only by aspirin. This has been stipulated that aspirin works much better in the other than cardiac atherosclerosis area. The stroke reduction is reduced only by aspirin, not by ticagrelor, not by clopidogrel. So that is why all-cause mortality was changed, whereas the cardiac mortality did not change in those groups where aspirin.
So before you drop aspirin, think a little carefully. I will bring to you match study. Match study is about stroke, which is actually when you give only clopidogrel after stroke, you don't prevent recurrences. That is one aspect we have to keep in mind. I will also bring to you the ISIS-1 study. ISIS-2 study.
Yeah.
35 days use of aspirin reduced all-cause mortality by 27%. You combined it, ISIS-1, sorry. Streptokinase alone reduced by 15%, combination by 43%. Streptokinase followed by aspirin, 43%. Streptokinase alone, those were the days you could afford not to give aspirin to a MI patient. Remember? Many of you are old enough to remember the ISIS-1 study.
Aspirin got its role in MI only after ISIS-2.
ISIS-1.
ISIS-1?
ISIS-1.
Atenolol. ISIS-1 was atenolol.
Yeah.
ISIS-2 was aspirin.
Sorry, ISIS-2. I'm a little confusion, but ISIS-2 clearly showed a much bigger benefit with mortality. Let us, I think John Cleland has been writing for a long time that let us bury aspirin. My feeling is it probably would stay alive a little more time.
Okay, sir. With that, can
at the same time,
we close this session?
You also have to remember that aspirin is the main culprit for bleeding, particularly GI bleed.
That's it. That's it.
Just
that aspirin in people who have very aspirin safer with acetylcholine compared to program.
Yeah, that of course is going on. There are trials now going on.
I think,
so, Dr.
I think,
Rajput,
Dr. Chandra, just last 1 minute.
Please.
I think there is, you have to rewind the whole clock again. We started with aspirin. It was good. We wanted something more. We had aspirin plus clopidogrel. Then clopidogrel had 33% resistance. So we found something better as ticagrelor and prasugrel. So now we have two. One is weak, one is stronger. So the time will come because ethically today, till now, it is not possible to do a trial without aspirin. But time will come as the data will come that why use two antiplatelets when one is strong enough and takes care of all the
let's wait for that day. With that, I close it here, sir. My submission. We are exceeding time.
This is what the
last session is on vitamin D.
Yeah.
So may I invite organizers to please come here?
I just want to say one thing.
Sir.
Aspirin has effects beyond platelets. Randomized study has shown that aspirin reduces blood pressure by 6 millimeter mercury, systolic blood pressure. Aspirin has other benefits, and although it has not been shown to have anti-cancer in ARRIVE and ASCEND, both trials, they thought that it will reduce colon cancer. It did not. But the fact is that the blood pressure lowering effect is consistent across all these studies.
In primary prevention causes more bleeding. So it's
absolutely, absolutely.
Sir,
primary prevention, no.
See the side effect of ticagrelor. It is much more than aspirin.
Okay. Yeah, the breathing.
Pegasus, actually,
complaints of breathing. Yeah,
the Pegasus, if you include, you do instead of NACE, then it is 9.9% versus 9.6%. No benefit.
The NACE is bleeding and ischemia both. Yeah, please. Come.
That is the trick. That is the trick. You see, the important thing is, no. Principal investigators can do this thing and get away with it. The companies are paying money,
In Compass also, they should have dual antiplatelet with aspirin plus.
Yeah.
I have a feeling that generally these are the rules of 93, and we could not find the correct dose of prasugrel. Yes, there's no probably 5 milligram is the correct dose. That's where the now researchers are found that prasugrel is the better. Same way, if you load 60 twice, maybe better than 95. This is need to be put by 5 milligram. 5 maybe 7.5.
Hello. Yeah. Thank you. And it was a nice discussion that we had. And now after this session, we would be moving on to our last session, wherein we would be discussing about the placement of vitamin D in the field of cardiology. How, because there are the evidences which some of the evidences say positive, some negative. So let's say how is it and where does vitamin D stands in the present cardiology practice? And for that, Dr. Sunil Modi, he is the mentor, and he guided us for this. And I'd like to invite Mr. Sambit Datta to welcome Dr. Modi on the stage.
Okay. Once again, sir.
Yes, sir. Now,
कुनको बुलाना है? Dr. Luthra, please come on the dais as a chairperson, and Dr. Anshu Kabra, please. I'm sorry, I have to ask him because there is no agenda left on my table and nothing given to us so far. But anyway, we didn't know anything about vitamin D 10, 15 years ago. I think 15 years ago, nobody knew what is vitamin D. At least cardiologists didn't know. My wife being pathology, they started doing vitamin D, probably second or third lab in Delhi, which started doing vitamin D. I got my vitamin D checked. It was 3. The whole family got it checked, 3, 4, 3, 4, 4, 5. And we were all healthy, running around, no pains, nothing, absolutely fine. So just to set the background. Then we started knowing more and more about vitamin D. I wrote a chapter in the CSI update on vitamin D, which I have completely forgotten what did I write. But anyway, vitamin D has been now more and more implicated in various systems like cardiovascular, neurological, peripheral nerve system, everywhere. And there is a good reason to think that it has a lot to do with the cardiovascular system, particularly with the statin therapies. There is evidence that statin works better if you keep adequate vitamin D levels, so on and so forth. And there are many, many issues, which I'm sure our speaker is going to tell us many new things also. The only thing I wanted to warn in the beginning is that I see many prescriptions coming from not periphery only, even from Delhi, which has 3 vitamin D preparations every week. So patient is taking 180,000 vitamin D every week. And I have admitted 2 patients in last 1 year with severe vitamin D toxicity, nearly dying person. Renal failure, hypercalcemia, 16 calcium. He was literally dying, and our nephrologist and others could help us in bringing him alive. So beware of vitamin D toxicity because it is being used by everybody. So doctor who writes the prescription doesn't know that patient is already taking. Patient doesn't tell the doctor that I'm already taking vitamin D. He gets a new trade name of vitamin D in his prescription. He keeps on taking both. This is common. So, we have a very good speaker on vitamin D, who is going to tell us vitamin D in cardiovascular system, and then we discuss about it after your speech. Please, sir.
Good evening, everyone. Looking like more of biochemistry topic, but now definitely it's now onwards. It's a cardiovascular disease, role of vitamin D in cardiovascular continuum. So we know since old times that vitamin D used in a skeleton purpose for calcium and phosphorus metabolism. But since 1994-95, the vitamin D role comes in the non-skeleton reasons also, in like diabetes, like immunity, cancer, and cardiovascular diseases. So definitely, are we really deficient in vitamin D? See, if we see the data, really in Indian people's adult population, around 80% of adult populations are deficient in India, while older population over the age of 65, 70 years, around 96% people are deficient in India. We know that less than 30 categorized as a deficient and less than 10 categorized as a severe deficiency. So we know this slide since long, that how vitamin D forms in the body by sun rays, chemical reaction in the epidermis, melanocytes, and then in keratinocytes, the vitamin D forms, and in the liver, first stage of hydroxylation occurs, and in kidney, second stage of hydroxylation occurs, and active form of vitamin D forms. So this is an old slide, and definitely after activation in the kidney, the active form of vitamin D forms. So after vitamin D forms, the vitamin D receptors actually all means the story started from the vitamin D receptors, and vitamin D receptors are present in cardiomyocytes, in the endothelium cells, and this is the reason why cardiovascular benefits are there probably. So vitamin D receptors are basically present in the cytosols, and vitamin D, when vitamin D react with the vitamin D receptors, it binds to the retinoid acid receptors, and then it migrates to the vitamin D receptor elements, and it gives a transcription and forms a protein. So basically it's a vitamin D, how it's doing action. So what vitamin D deficiency occurs? What is the reason behind that? That what is the hypothesis postulated in vitamin D deficiency in the cardiovascular disease outcomes? So first of all, this relative vitamin D deficiency, basically what we can say that vitamin D inhibits the renin system. So relative vitamin D deficiency it activates the RAS system. So we all know that renin is implicated in the implicated in the hypertension, left ventricular hypertrophy, fibrosis, vascular smooth muscle cell hypertrophy, and hypertension. Ultimately, the result is hypertension or left ventricular hypertrophy. The other effect is the relative hyperparathyroidism, which causes hypercalcemia and other things, and pancreatic cell dysfunction. So all things lead to diabetes or pre-diabetes status, and these all leads to increased atherosclerosis. And one more theory, vitamin D deficiency increase the inflammatory cytokines. So basically all leads to atherosclerosis and ultimately causes more of cardiovascular problems like MI, stroke, or heart failure. So those people, who are the people that those are mainly deficient in the vitamin D, like kidney disease, malabsorption syndrome like celiac disease, Crohn's disease, or gut surgeries, inadequate sun exposure, age, inadequate sun exposure, those who are the far away from the equator where the sun lights are not proper. So sun exposure, dark persons, liver failure, smoking, obesity, where the fat contents are more, the fatty peoples are more of the diabetic deficiency, and breastfeeding females. So these are the candidates who really are the vitamin D deficiency. And in these vitamin D deficient persons, the RAS system, inflammatory cytokines, vascular calcification, and myocyte flux are more, and these lead to cardiovascular disease, means increment of the cardiovascular diseases. So vitamin D deficiency, just I told, it's increased the inflammatory cytokines, especially in interleukin 4, interleukin 5, and interleukin 10. So now vitamin D, its new defense against the cardiovascular disease. This is the current atherosclerosis in 2017. Vitamin D, calcium, and cardiovascular disease, advantageous or detrimental, era of uncertainty. So vitamin D deficiency is associated with hypertension. This is basically European Journal of Epidemiology in 2013, which clearly show in hypertensive people, the blue bar clearly shows that those who are vitamin D deficient has a hypertensive prevalence more than those who are not with vitamin D deficient. While in non-normotensive person, we can see vitamin D deficient people are not there in yellow bar. So 43% are those who are not vitamin D deficient as a normotensive. So vitamin D deficiency and hypertension. This is a Lancet 1998. This says that ultraviolet B radiations from tanning 3 times a week for 3 months led to nearly 200% increase in vitamin D level and 6 mn decrease in the both systolic and diastolic blood pressure. While NANS 3 in 2007, it says the average systolic BP was nearly 3 mm lower in subject with the highest quartile of vitamin D compared to the lowest quartile. So basically, they all shows that who are vitamin D deficient had a more chances of hypertension than those who are not vitamin D deficient. So this is basically a relationship between the vitamin D and hypertensive cardiovascular diseases. So basically, they shows the 6% cardiovascular disease risk could be prevented by increasing vitamin D concentrations. So all three graphs shows vitamin D deficiency less than 20 nanogram per ml is associated with MI. So basically, all studies shows these are all not means prospective trials. These are all observational studies, cross-sectional studies. Prospective trials are not there. So vitamin D deficiency is associated with MI. So vitamin D status is an independent risk factor. It's significantly linked to incident MI, worse short outcomes and recurrent MACE. So basically, I just already told activation of RAS, LVH, myocyte hypertrophy, atherosclerosis, cardiovascular disease outcomes, increment. So all these associated with low vitamin D deficiency. Now, one most important thing, low vitamin D deficiency also associated with abnormal lipid profile. So how it's possible? Means those who are a high, vitamin D deficient at a high total cholesterol level, LDL cholesterol level, even triglyceride levels. So they given the hypothesis that vitamin D affects circulatory cholesterol levels through transcription activity of vitamin D receptors and insulin-induced gene 2 expression. And insulin-induced gene 2 expression down-regulatory, sterol regulatory element binding protein 2 activation, or all these lead to reduce HMG coenzyme activation and reduce cholesterol synthesis. This is a hypothesis they given. And now the monthly high dose vitamin D supplementation lower central blood pressure among adults with vitamin D deficiency. So this given in the American Heart Association 2017. So basically, these all support that probably vitamin D given a good outcome in the cardiovascular benefits. But some recent trials which comes in the means vitamin D trial or other trials, they shows probably they not given a benefits of vitamin D deficiency in cardiovascular benefits. So one AVITA trial is there which shows vitamin D supplements are beneficial in heart failure patient in NYHA class 2. In advanced heart failure patients, vitamin D supplements reduce the requirement of mechanical circulatory supports.
That last slide is very important before this. Before this slide. This slide. And this is the latest data of 23. Please tell us about this.
Vitamin D supplementation limited benefits in the mortality, MI, stroke, heart failure, MACE on extended MACE. So basically, this shows that myocardial infarction, stroke, heart failure, MACE or extended benefits are, we can see there are, we can see those who are taking vitamin D, favors vitamin D, they had a vitamin D, means they had a extended benefits. The curve we can show is turned to the left side. So they shows a data that they given vitamin D supplementation those patients and they had a clear benefits in the mortality, MI, stroke or heart failure. So basically the decrease in the MACE events by this data. So vitamin D supplement are beneficial in heart failure patients. Some studies were suggesting no benefits in the heart failure patients. This is the effect of vitamin D in AVITA trial. I just told you a 3-year RCT with 4,000 unit international shows no benefit in the heart failure data. And some small studies, those are the prospective randomized trial, shows no benefits in the hypertension like Zorde, Scrag. They say long-term high-dose vitamin D3 supplementation and no benefits in the healthy adults. So basically, some prospective studies do not support vitamin D supplementation, while cross-sectional observational studies in the past with a large number of patients supports the vitamin D supplementation in cardiovascular benefits. So vitamin D has been known to affect various systems and contribute to the underlying pathology of many diseases. However, various clinical studies in vitamin D replete individual have demonstrated no benefits in the global health, and there is enough and robust evidence that vitamin D deficiency associates with adverse outcome in various cardiovascular conditions like hypertension, CSD, heart failure, and dyslipidemia. And benefits of vitamin D supplementation not concretely proven in some individual RCTs. In last slide, thus it is recommended that vitamin D can be used wisely and given to those who need it. So basically, after this complete presentation, the RCTs or cross-sectional studies till now means no prospective data for vitamin D long studies there, but cross-sectional and observational studies definitely support vitamin D supplementation. Thank you.
Thank you very much. Just few basic questions I want to ask, because you must have recently studied about vitamin D. Why are we deficient in vitamin D? Is it only sunlight exposure or some other reason?
Maybe dietary reason is also there.
Does vitamin D come from diet?
20% is come from diet, but 80% like dark skin people, we are.
So exposure to sun is fine, that we know.
Yes.
Is there any other reason? Diet may which diet?
Fatty fish and fish oils and.
So what diet you will recommend to a patient who is severely vitamin D deficient? What special things you will recommend?
Fatty food.
Which fat? He asked, "Doctor, क्या खाना है?"
Fat is better.
नहीं, fat मतलब घी या मक्खन या क्या चीज?
Milk products we can take.
Milk products. Okay. The milk is the main source of cholesterol. Anyway, so that is one thing. Second is, what is the connection between vitamin D and calcium? Is there any connection, direct connection of vitamin D and calcium?
Vitamin D in skeleton is
no, other than skeleton. From the cardiovascular point of view, patients
it increases the influx of the calcium in the myocytes.
So there are
excitation, injection of
why I'm asking, most of my patients have absolutely nice fine calcium, but they are very low vitamin D. Does it tell us anything? Because most of them are normal calcium.
The calcium level is maintained by parathyroid hormone also, by causing demineralization of bones.
Okay. What?
No, sir. See, active vitamin D is 125 hydroxy vitamin D. We usually measure the vitamin D, which is in the storage form of the vitamin D. So, means vitamin D is deficient. Doesn't mean that.
It doesn't mean that calcium will also be deficient. Yes. Okay.
Probably.
सर आपने बताइए आप खाते हैं
क्या चीज?
विटामिन डी
खाते हैं once a month 2000 units per day or 60,000 once a month. So what is the normal level which you would like to see in your patient vitamin D? Because laboratory says 30 to 250. No, 30 to 250 is normal. No, toxicity above 250. That is what laboratory.
Toxicity is about 150.
150, some laboratory says 250. I think there are different methods. So, what levels you are happy with your patient?
If patient comes after that more than 40 nanogram per ml, it's okay. More than 40, 50 nanogram.
20 is low?
20 is low.
That's low. Okay. I have read somewhere, and I think I can quote that also, that vitamin D below 10 is to be treated. Above 10 may not need a treatment. I mean, that may be just not the correct answer, but then very low vitamin D definitely needs treatment. Little bit of low vitamin D may not.
Many RCTs are there in which they treated 21 to 29 nanogram per ml and below 20 and more than 30.
So this given the benefit that in 20 to 29 ml per nanogram per ml, if you will give vitamin D supplementation, the hypertensive benefits are there. Means the patient headache means less chances of hypertension.
Vitamin D benefits heart only if it is low. Otherwise, if vitamin D levels are normal, then giving vitamin D doesn't benefit cardiovascular system. So it is only the deficiency which you want to trigger.
Sir, I want to ask one question. Yes, sir.
I just, yeah, please go. Please go.
Further questions?
I will tell you anecdote, and of course, there are two randomized studies available with vitamin D supplementation. One is called VITAL. It is a study of 25,871 patients from United States above the age of 50 years for men and above the age of 55 years in female, because they have more chance of cardiovascular events. Supplementation with vitamin D given for 5 years, follow up the two co-primary endpoints, new onset cancer and the cardiovascular events. Both did not achieve statistical significance. In these 26,000 patients given a placebo against vitamin D, 5 years follow-up, vitamin D did not reduce cardiac events or cancer. That's the first study. The second study, which just got published a few months back, is called D-Health study. Now, the D-Health is a very important study, an Australian study looking at all-cause mortality in people above the age of 65 years. Now, that is very important study because they high mortality in 65. And that again showed that absolutely no benefit of vitamin D supplementation, 60,000 units per month. 60,000 units per month. So this is a study of 27,000 people. So all in all, whatever randomized studies are there are not showing benefit of vitamin D. With regard to the levels, I will tell you an anecdote. My father actually did BA from Lahore Government College, and he lost his degree. He came to combined Punjab and applied for a job, any job. So he applied for a lot of jobs, but they said, "You have a certificate of graduation?" They said, "No, I don't have a certificate of graduation." So eventually he was to be selected for a post, which was an administrative post, and there was this commissioner, ICS, in those days, who was a Jat. So he said, all the people, candidates line up. And he says that is the scale 6 feet. All those who are above 6 feet are selected, and those who are below 6 feet are rejected, out. So this vitamin D, reminds me of that. Who decided that 25 nanogram or 30 nanogram is a normal value? Doesn't it appear to you that it is a major flaw in the whole system?
If we say 90% people are deficient, then this point further gets the significance. In that case, who decided the normal value?
No, the difficulty is, it is the same way we decided the total cholesterol 250 was normal. Remember 1948 Framingham study? That was the time. That was the same thing we said, the HDL has to be above 14 men, which we still are following. Your HDL has nothing to do with what is happening to your cardiovascular system. But we are going on with all that. This is the unfortunate thing with science, actually. There is a strong lobby which wants that you should do vitamin D levels. There is a strong lobby which says that vitamin D supplementation should be given. I can make an argument that below 10 nanogram probably should be given. During this COVID period, I was in 10 or 12 webinars, and I told all the experts, international and national, show me an iota of evidence that treating even less than 10 nanogram helps the patient as with regard to cardiovascular system and diabetes.
But I tell you, Dr. Mohan, in this practice, do vitamin D levels low, patient complaining of vague symptoms, give vitamin D, symptoms improve. So for a clinician,
this is the placebo effect.
For a clinician, exactly.
This is the placebo
what I'm
effect.
saying. So for a clinician, it has become a boon that given vitamin D, patient improves because his vitamin D is low.
Yeah.
At the same time, There is a entity which you are reading since medical college. There is a situation called vitamin D deficiency. We might debate on the level.
That was for skeletal problem. Vitamin D, we all understand. We have had full chapter of vitamin D in the bone and skeletal system. That part is very well understood.
We are debating the level. We are not saying vitamin D deficiency is no important. We are saying what should be the level. Less than 10 nanogram rather than 30 nanogram.
Sir, I want to
apply to cholesterol levels also. Who decides what's the normal?
Yeah, absolutely. The same way you actually take up a population, actually study 100 people, and then you find out this is the mean plus minus standard deviation. That is what you are saying. Methodological error can be there. Which method you have used?
One moment,
Vitamin D is responsible for absorption of calcium from intestine. That is the role of.
So if
vitamin D is must for absorption of calcium from.
Absolutely, that is what I read. So
you're saying the deficiency vitamin D, but calcium is low because parathyroid hormone is maintained.
Exactly. So
because serum calcium level is important.
Absolutely.
For
So
the contraction.
that means patient.
Depolymerization is happening.
Yeah, that means patient who
Parathyroid hormone.
yeah patient.
That is maintaining your calcium level, but vitamin D is must for
Perfect.
absorption of calcium.
Perfect. So patient who has very much deficient vitamin D should also have deficient calcium.
No need.
What Dr. Modi
should have some abnormal. So very low vitamin D patients have been studied. Normal parathyroid hormone, normal calcium.
Yeah.
How do we explain that?
So point is, true vitamin D deficiency should cause secondary hyperparathyroidism.
Yes. But we don't see. We don't see secondary.
If secondary hyperparathyroidism is not present, that vitamin D deficiency is not relevant to the human being.
This is exactly what I was
actually. We never done means how many we are doing in relative vitamin D deficiency PTH levels. Nobody is doing.
We should always do that. If the PTH levels are high, above 65,
so
international unit, then only you should say vitamin D deficiency is significant.
Is there any study like that?
No, this is simple concept.
I don't know.
It can affect heart multiple different ways, but
When you supplement it, as you said in two trials, there's no benefit.
no, we also realize in Women Health Initiative where people criticize WHI study saying that they had only used 400 units of vitamin D per day. That study said fractures are reduced, but cancer and cardiovascular effects are not there. People criticize WHI study 20 years back saying that they use only supplementation 400 units of vitamin D, which is too less to make a meaningful difference. So these two studies, Vital and the D Health, looked at 22,000 units per day actually for 5 years. And since this being a fat soluble, it would stay in the body actually. For 5 years, it will make a huge difference.
Okay, Dr. Mohan, I'll ask you a specific question. When patient comes to you for a complete health checkup, do you do vitamin D in
No,
that?
I don't do it.
You don't do it.
I
Dr.
don't do
Rajput, do you do vitamin D in every patient who comes for? It is part nahi. Suppose you have your own clinic, you will do it in every patient who comes for health checkup. How many?
One thing is there, sir.
It should be done.
Vitamin D should be done only if you touch the bones and bones are tender, then you should do a vitamin D.
So that is another concept. How many people will do it in a healthy individual coming for health checkup?
Sir?
Just raise the hand.
Most of the patients, they do come with report itself.
No. That's actually a wrong thing. But when patient comes to you that I want a complete health checkup, doctor, please write the investigations. It should be done. It should be done only if bones are tender.
One thing I tell you.
Should it be done in every cardiovascular patient? Because patients coming to us are all cardiac patients. So which cardiac patient you would like to do vitamin D levels?
Those had a symptoms of, like the sir told, like tenderness of the bone,
So
or
you are now from cardiovascular going to the bone system.
no sir told bony tenderness or severe weakness in the weakness or numbness, means they told the
So any
generalized
symptom.
symptoms.
Any
So
vague
we-
symptom.
any vague symptoms, severe symptoms, difficulty in standing, or they had as symptoms like
No
okay.
other vague symptom, only cardiovascular symptom.
No, cardiovascular symptoms usually will not do.
Sir, there in the recent articles, in
Acute
the
MI, all acute MI should be done.
No.
You have just shown the correlation of MI and
Sir,
vitamin D.
sir, given me topic to present vitamin D.
sir, 1 minute, sir.
No,
Sir,
it's interesting.
in that
Interesting
one last, sir.
What I do in
In
my
the
practice,
recent New
see,
England-
again, we have to learn from each other. What I do in my practice, of course, patient comes, wants a complete checkup. He emphasizes on complete checkup. We do it.
Sir, in the recent article in the New England Journal of Medicine, obituary has been paid to the vitamin D. Obituary has been paid. He has had billions of dollars have been swindled just for the sake of estimating the vitamin D and giving the vitamin D. There is no point in doing the vitamin D. Neither it prevents heart attacks, neither it prevents the bone fractures, neither it has got any role in any disease.
Many of my colleagues in the hospital say exactly the same thing.
Second thing,
I don't say the same
this
thing, but many
debate-
of my colleagues
you know,
say this.
this whole thing came out because the man who actually propagated the myth of vitamin D was from Massachusetts state. I think he was from
Yes, sir.
Boston.
Yes.
And I think this man had a patent for vitamin D analysis. And he made millions of dollars. And he perpetuated that myth for a long time. I did not want to talk about the New England Journal of Medicine editorial because it would hurt a lot of people. But happy that you brought it. This is exactly what I have been following for 20 years.
And sir, regarding the diet, in our country, the most robust community, the Sikhs, our brothers Sikhs, they are also deficient in vitamin D. So
everybody is deficient in vitamin D.
But I am telling you, telling about the diet.
स्टोरी बताई ना भाई जो 6 फुट से हैं
How to level the efficiency?
अभी तो कह रहा हूँ उनको 6 फुट से नीचे उनको जॉब नहीं मिलेगी 6 फुट से ऊपर उनको जॉब मिलेगी.
No, I think this is an important thing for us.
Let's
to
come on a
decide.
slightly humorous mode. बहुत serious talk हो गया. I'm a product of King George Medical College, Lucknow. So there was a department of social preventive medicine, which was upgraded department. I don't know why it was not upgraded, And we had one Dr. CMS Sidhu as head of the department. The Dr. Park was also from the same department. Sadarji. His brother was member of parliament. For us as a student, MP was very, very big thing. So there was no electricity in those days. I'm talking about 74, 75, 76. So what he will do, he will sit on a chair, keep his legs on the table. Those who are ready to cross below are passed. Those who are not ready to go are fail. This actually happened.
Sir, how we'll conclude this session? Vitamin D, final take home message. Take home message.
No.
Take home message.
As a...
No, sir, take home message should be done.
Message is, take home message is enjoy life. Enjoy life, forget vitamin D.
As a mentor, my take home message is that do it once at least. If it is very low, and I call very low, maybe below 10 or maybe below 20, you can say, give some treatment. Whether it helps or not doesn't matter, but patient is always, if patient finds something low in his body and is treated, he's always happy. That doctor साहब ने ये चीज पकड़ ली. Whether that symptom is connected with vitamin D or not doesn't matter. But as a practitioner, they
friends, let's say
always appreciate.
Thank you. This was again, as the previous 3 sessions, quite debatable, great discussions happened. And for me, it was the feast of the event, the whole one, though it was a bit lengthy, I feel. Some of the people might feel that it was a bit lengthy. Sorry, sir?
Where are we next?
Immediately, sir, quite soon. But this was amazing, quite a knowledge feast for me. And I would like to thank every one of you. And now I'd like to invite our CEO, Dr. Vijayesh Gupta, as well as Mr. Samrit Datta, to honor the men of this event, our course director, Dr. J.C. Mohan sir, because without the guidance of him, this would not have been possible at all. So we would like to show our gratitude to him.
Full light on करेंगे सर? हाँ जी सर. Light on कर. आगे कर. Just hold on. Full light on. Full light on. ये सर. Reflection आ रहा है.
बंजा at least कुछ रख दो साइड में.
Yes.
Thank you. Yes. Yep. Son.
I think we are the fag end of this session, the day. And I really thank you. My name is Sambit Datta. I think by now many of you have already come to know about it. And on behalf of Kerala, I like to share my heartfelt thanks for all your time we spent with us this day. And we look forward for more such events in the future also. And let's make Cardiosphere one event as a platform for scientific exchange in the field of cardiology. We like to do more such programs in future. I'll not take much time in this Thanksgiving speech. The session was really, thought-provoking, and a lot of ideas came out, and I'm sure all have enjoyed. Thank you very much. All the best. Have a nice evening ahead. Okay, now for all the participants, all the faculties, all the panelists, from behalf of the Cardiosphere, we plan to give you a memento and a certificate, which we will present you the same memento and a certificate we like to present you at your respective chambers. Along with our team members will reach out to you. Thank you very much. Thanks for your valuable time. Thanks for all your. And at the same time, there's a gala dinner planned on the first floor, for one level up. So I request all of you, please join for a gala dinner and have a fantastic evening ahead. Yeah, thank you.